sazi into yokokuba wena sesele usikhokhele. Sigcine ngoku idibu iNkosi yethu Yesu Kristu. Amen.
Enkosi mfundisi. Also, comrades, I must acknowledge the presence yethu ukuthi sinaye ucomrade uEric Motau. uEric Motau is coming from UNAIDS. Ulapha. And also I must acknowledge the presence yethu sinaye ucomrade Thando Xolodorho. Thando Xolodorho is coming from USID. Ucomrade Thando Xolodorho is one of the people who started this movement of making sure that we are taking a lead in responding to problems and challenges of people living with HIV. The program here to comrades. Before I go to the program, but I think also I must mention comrades. Before siqhubekeke, zawucela iphone zethu sisifake ku silent because kunabantu aba online. So always xa iphone ikhala bazaphazamiseka aba. I must confirm kule nhlanganiso and to everybody ukuthi Tuesday besinenhlanganiso kunye no MEC of Health nabo Dr. Somayela where besipresenta khona le report ku MEC. Sabonisana ukuthi ubheka phambili sokwenza njani. Also, as we are starting this meeting, I want it to be on record ukuba eMotherwell eThando Xolo clinic nase NU11 clinic eMotherwell for the past 4 weeks iclinic ivaliwe abantu abawafumana amayeza. The question you must ask, what about people about chronic medication for 4 weeks not getting a treatment? Ngibhalile email kuTatu Somayela na ku office ka MEC no district chief director uSenelson Mandela uMrs DeForce no Mr. Dayile from Sanak no Mr. Mabalane from Sanak asking them ukuthi this must be resolved as a matter of urgency because we're talking about the lives of the people here. If those people are not given medicines, it therefore means baza defaulter, and if by defaulter, xa bebuyela back with treatment yabo, chances of them developing resistance are very high, and then we will blame them for getting ukuthi clinic bivaliwe. Sicela ke no MEC as umuntu osemagunyeni asincedise ungenelela kwinto eyenzeka eThando Xolo clinic eMotherwell nase NU11 nakuzo zonke ezinye clinic apha eEastern Cape. Iprogram yethu ke namhlanje izama ngohlobo kuza kule report kuzawuxoxwa ngezinto ezidibene kunye ne-staffing and waiting time, izinto ezidibene kunye ne-infrastructure ne-conditions ze-clinic zethu, umcimbi we-collection of anti-retroviral treatment continuity, issues around treatment siphucula imeko ze-clinic zethu kwenzele into ukuthi wonke umuntu ongummi waseMzantsi Afrika ohlala eMzantsi Afrika nosebenza eMzantsi Afrika ufumana inkonzo zezempilo ezingcono ngoba kaloku eli lungelo salinikwa ngo-1996 ngexesha sasi approve i-constitution ye-country phaa ku-constitution section 27 of the constitution. Section 27 of the constitution gives us a right to access quality healthcare services. And if that right is violated, it therefore means our rights are violated and we need to stand up and demand for our rights. That's why silapha namhlanje. Asange uzodemand, sizobonisana kunye notata uSomayela nabanye abakhoyo apha o-UNAIDS, USID, PEPFAR ukuthi as much as kukho imali eninzi eMzantsi Afrika yokuphucula imeko zezempilo, ukuphucula imeko around HIV, TB, services key populations, but pha ekuhlaleni asiziboni izinto ezi. Singenza njani ukuthi ezi services zi-improve? Without wasting any time, I will hand over to my comrade Ndivuko, to lead us, and then we will take it from there. Yabulela.
Thank you, GS. So we're just going to go into how the report was developed. As stated by the GS, this is the second edition of the Eastern Cape State of Health Report, developed using data from Ritshidze. Ritshidze monitoring takes place on a quarterly basis at 50 facilities across the Eastern Cape, 9 in Alfred Nzo, 6 in Amantole, 12 in Buffalo City, 7 in Chris Hani, 1 in Nelson Mandela Bay, and 15 in OR Tambo. Additional quantitative and qualitative data is collected within the community specific to service acceptability and availability for key populations specifically. Data are collected through observations as well as interviews with healthcare users, public healthcare users, people living with HIV, key populations, and healthcare providers, which include facility managers as well as pharmacists. All our data collection tools, as well as our data dashboard and all of the raw data, is available on our website. So the data in this report were collected between July 2022 and August 2022, which is our Q4 in Ritshidze. Interviews took place with 50 facility managers. Observations took place at 49 facilities. Interviews took place with 2,479 public healthcare users, of which 51% identified as people living with HIV, 72% identified as women, and 26% identified as young people under the age of 25. Additional data were also collected that are related to key population, was collected between August and October 2021. The data collection took place across 2 districts, namely Amatole and OR Tambo, and a total of 674 surveys were taken, combining 189 gay men, bisexual men, and other men who have sex with men. The abbreviation for that is GBMSM. 403 people who use drugs, 63 sex workers, and 19 trans people. Just to touch a bit on the limitations of community-led monitoring, Ritshidze is not a research project. We are not in any way testing any hypothesis. Community-led monitoring is more akin to independent M&E than it is to research. Some of the limitations thereof include issues around generalizability, where results are from the facilities monitored may not be generalizable to other facilities in the district or in the province. Secondly, in terms of facility heterogeneity, facility results, even at the district level, are heterogeneous. Challenges and successes should be approached as facility specific unless results consistently identify poor performance and policy level issues. And lastly, we need to just touch on the non-representative sampling of public healthcare users. So public healthcare users identified and interviewed at the facility are not necessarily representative of individuals who may have stopped accessing services at a facility. As such, further qualitative data is collected in the community to capture the experiences of people who may have already disengaged from care. So now we're going to go into our first set of issues, which is around staffing. So ensuring that we reach the 95, 95, 95 targets depends mainly on having enough qualified and committed staff in place. Last year, 11% of facility managers reported that there were enough clinical and non-clinical staff to meet demand. While there has been an improvement, this year only 14% of facility managers reported having enough staff. Of the facilities with data in both reporting periods, 5 facilities have improved across the time period, now reporting enough staff to meet patients' needs. However, 3 facilities have worsened, now reporting not enough staff to meet patients' needs. There is still a long way to go to fill the human resource gap, as 86% of facilities monitored remain with too few staff to meet demand. When we do interviews with public healthcare users, this also reveals no improvement since last year. In this reporting period, only 21% of public healthcare users interviewed reported that there are actually always enough staff at the facility. There's a considerable variation per district. 18% of respondents in Alfred and Zor say there's always enough staff, 53% in Amatole, 6% in Buffalo City, 13% in Chris Hani, 13% in Nelson Mandela Bay, and 32% in OR Tambo. This has stayed roughly the same as last year's reporting period, where 27% of people said there were always enough staff, and 28% said that there were never enough staff. When it comes to understaffed cadres, according to facility managers, the most commonly understaffed cadres were cleaners at 28 sites, professional nurses at 27 sites, data capturers at 25 sites, doctors at 22 sites, and enrolled nurse assistants at 20 sites, and general assistants at 8 sites. Following a decline in the number of unfilled vacancies reported across the year this quarter, we saw an increase again to 319 vacancies open across 30 facilities. Key positions still remain open, creating gaps in the capacity to deliver quality services. The most common vacancies by cadre are professional nurses, where we have 74 vacancies across 19 facilities, cleaners, which is at 66 vacancies across 19 facilities. In terms of enrolled nurses, there's 43 vacancies across 13 facilities. When it comes to data capturers, 32 vacancies across 17 facilities. And with doctors, it's 30 vacancies across 15 facilities. Moreover, 52% of facility managers we spoke to specifically wanted additional human resource for health support from PEPFAR district support partners. In the Eastern Cape, this is Match and TB HIV care. However, PEPFAR's funding for critical HR posts has only reduced in recent years. Overall, not much has changed since last year's report in terms of staffing, although positively, there has been a reduction in the total number of vacancies in the province. A gap still remains between the staffing needed to ensure high quality services and the staff present each day at site level. Now we're going to move into some of the recorded community stories. In this session, we basically hear from community members who have stopped using the facilities in other instances, and we will go into the communities to hear their experiences of what happened, what are their feelings around going back to the facilities for care. And we also do have community members who are in the hall who are with us, who will also share some of their testimonies as well.
Mna ndihlala apha kwa-NU1, ndikliniki ePhilani kliniki yalapha e-NU1, ndicwangcisa khona. Ndithe ngoMeyi, zinintsi ke izikhalazo phaa, but esona sandiqonda uba sindinika umnqa kwakungoMeyi ukuba ndicinga kakuhle, ndiyocwangcisa phaa ngezithuba zo-1 ngoba ke abafuni mntu kusasa, bathi masize emva ko-1. Nyhani ke siye ngo-1, safika igeyithi ivaliwe. Kume unesi oyindoda okuthiwa nguSoso, andazi amagama akhe, ibizo husband wakhe. So baleqa kwi-memorial service. So ke ngoku wam umbuzo uthi kunyanzelekile uba baye bonke kwi-memorial service na? Womntu omnyeni, womntu ophangela phaa na? Sagxothwa ke saphela singacwangcisi loo mini leyo. Andiyazi abathethi nathi. bathi thini na isizathu. Mhlawumbi ke i-shortage of staff asiyazi, but kaloku asizuzicingela loo nto leyo thina. Nithi xa nifika kuthiwa iinaliti azikho, iinaliti azikho ziphelile, kuthiwa phindani nibuye, uphinde uyotshekisha kuthiwa azikabikho. So ziphela ke ngoku siya amanqaphanqapha ke ngoku ezinalitini njalo, bakhona ezo problems ezo.
Ndiklinika kwi-N1 clinic. Yeah, and ke ndingumntu o-HIV positive. So apha ke ekliniki into endizikhalazela zininji. Njengoba bekhe sayiphatha i-attitude yapha is not good enough. For example, abantu phayana uyakwazi ukuthi kunetha imvula kuthiwe phumani phandle. There's no waiting room, nothing. Uyakwazi uyothatha just for treatment. You have to wait for 3 days because jonga ngoku bendivele uthatha i-treatment bendifamba ndiyifumene ngoLwesine kungona ndiyifumane so. You know, andiboni into irongo more than i-service. Indlela abasebenza ngayo ayikho strategic. Kusetyenzwa nje umuntu usebenza loo nto ayithandayo. Esi siqhumo xa nisebenzayo cannot work as individual. Kaloku uyaphuka ekliniki bakufika ixesha loba batshayise bahambe. And xa befikile laa xesha lotshayisa bayahamba banishiya niphana ukhala nobani bangaphi na.
NdingowaseMevana elusikisiki, sebenzisa i-village clinic. Ndaba nengxaki ngenye imini e-village, ndanikwa iipilisi ndigula. Kwakho iipilisi ezindigabhisayo kakhulu. Ndathi kodwa kho le ngxaki yale pilisi andikhange ndiqhubeke ndiphinde ndiyisele le pilisi. Ndayiveza ndiyiphethe epesini. Yathi inesi, ipilisi le ifana nezinye iipilisi, ayikho le nto ndiyithetha, le pilisi ndiyinikela uba indikline, ndiyazazi uba ndiyagula. Yandiphatha kakubi le nto yale pilisi ngoba le pilisi bendicinga uba mhlawumbi unonditshintshela ngoba yona iyandigulisa. Ndabuya ke ndingakhange ndifumane uncedo, ndigwexiwe nje uba ipilisi ifana nenye. Waphuma elantukeni kwindlu yakhe apha wayobiza enye inesi wathi mayizawumamela le nto uba le pilisi ikhe yenze ntoni na. Uthi lo mama buyise le pilisi, siya ekliniki sigula kakhulu, kambe abanye abantu badala. Ekliniki sima ekuseni ngo-8 kuyobetha u-2 o'clock, sikhona singeniswa ngeli xesha thina. Aba sisi bayancokola abaqeshwe phayana, nje umsebenzi wabo bawenza kancinci. Wesi bangxole nongxola bathi sifika ngoku emalanga, sifike ngo-8.
So now we're going to move to the community stories. All of those who've been given number 1, please, it's your time to speak.
NdingowaseLusikisiki, ndiklinika e-village.
I'm from Lisugisiki. I use a village clinic.
Bendiye last month ekliniki ndiyocwangcisa.
Last month, I went to the clinic for my contraceptives.
So ndiye ndaya phaya, xa ndifika phaa ndafikela kwenye inesi yandibuza ubana kutheni ndicwangcisa ndimncinci kangaka.
When I got there, I got to meet the nurse and she asked about why do I prevent when I'm still too young.
Kwabe kukhona abanye abantu babephaa phandle ke endikhwazela phaya endibuza ubana kutheni ndicwangcisa ndimncinci sendilala namakhwenkwe na.
There were many people outside and she shouted at me, asking me that do I have boyfriends now that I want to prevent.
So mna ndaye ndatsho ubana ndize lapha ndizocwangcisa nje ndifuna ukugqiba isikolo ndingakhange ndimithe.
I told her the reason why I wanted to prevent is that I want to finish school before I can fall pregnant.
Kodwa ke ndaye ndalentuka baye bandicwangcisa ekubeni sebendiye bandishawutela ndaqonda ubana andizuphinde ndiye kulaa klinikhi because phaa abanye abantu babhekela phantsi.
So after being shouted at, they eventually helped me and they gave me my contraceptives, but I felt bad and I felt that I don't want to go back there.
Okay.
Thank you.
Okay, thank you. We're going to now move into recommendations. The Ritshidze recommendations state that by June 2023, the Eastern Cape Department of Health should fill 70% seats in the province, including the 300
of 3 hours, 59 minutes waiting in the facility. This includes a time before the facility opens, of which an average of 3 hours, 47 minutes is a waiting time after the facility opens. It is just above the national average, while the waiting time was under 3 hours at 4 facilities monitored. The average waiting time was 5 hours or more at 5 facilities monitored. This is a very long time to spend at the facility in which public health care users are usually only seen for a short consultation. Because of the long waiting period, public health care users begin queuing early in an attempt to get seen more quickly. All monitored facilities open between 7 a.m. and 9 a.m. Yet some public health care users start arriving before 5 a.m. in hopes of being seen early. Out of 956 people who arrived before the facility opened, 45% reported feeling very unsafe or unsafe while waiting for the facility to be open. Key measures such as opening the grounds early and spacing out appointment times throughout the day should be put in place to ensure that people are not put in danger or unsafe condition while waiting for healthcare. 60% of public healthcare users interviewed in the province think that the waiting time at the facility are long. This has reduced since data collected between October and December 2021, where 69% of public healthcare users thought that the waiting time were long. This varied slightly across districts, whereby 67% of responded in Alfred and so think that the waiting time are long. 42% in Amatole, 75% in Buffalo City, 59% in Krizani, 100% in Nelson Mandela Bay, and 46% in OR Tambo. The most frequent reason provided by public healthcare users for the long waiting time is that there is not enough staff in the facilities. we stand at 66%. Staff are not working or working slowly, it gives us 38%. And there are those that says that it takes too long to find files. The filing system is messy, files are lost. So it stands at 30%. Out of 2,030 public healthcare users, we have 64% who think that extended hours will improve access to services. Ritshidze observations reported filing system to be in good condition in 54% of sites. This has improved since the same reporting period last year when 54% of filing system were observed in good condition and 54% in bad condition. 8 facilities improved in the year, 5 facilities got worse. Messy and disorganized filing system only add to waiting time as staff are delayed in finding files or lose files altogether. Some patients report having to open new files with all patient history lost. We're gonna go to the recommended stories.
Ndingumhlali waseNorthcrest. Ndisebenzisa ikliniki i-Civic Center. Yinto yoba sifike sifole ngapha kweyadi, sifolele ungena. So laa nto isilibazise kakhulu and napha ngaphakathi siphinda sifole. Enye into ke iphinde isilibazise ziifayili, ukukhangelwa kweefayili. So iye isilibazise kakhulu ngoba awenzi kwanto ungakafunyani ifayili yakho. So uyalinda.
Kwalapha eMqanduli ngethi inomgama osuka apha uyotsho ekhaya kwa-2 kilometers. Yabona ndifumana i-treatment yam ke once ngenyanga ezimbini. Uyabetha ngexesha u-1 ndisela and i-dispensary lapha iyavala ngo-1 iyovulwa ngo-2. Uba ufika apha 12 ngo-1 umanisi ufike hamba athi uzubuya ngomvulo siyagoduka thina. Zenye zeento ezingandonelisiyo kule kliniki ezo. Uba ufika ekliniki apha eMqanduli ngo-1 uyawufika ungekho mntu. Hayi asitho njalo leya lapha ke eMqanduli le sikuyikliniki ngoku le Qanduli Community Health Center. Uba ufika apha ngo-12 okanye 1 o'clock hayi ubuhleli phi siyahamba thina uzubuya ngomvulo. Yho hayi ndonwabise xesha nje uba ndingumntu olusayo. For instance bendilapha nge-7th kaJulayi ndemka apha ngo-3:30 ndofika kha ngo-2, 4 kwapha kutshona ilanga apha iigusha zam azange ziphelele.
Xa ndifika apha ekliniki eMqanduli mhlawumbi uba ndifike I think ndifike ngo-8 ndiyoze ndiyohoya emva ko-10. Itritmenti endiyithatha ye-HIV ifike andineli kakuhle ke ngoba indawo sihlala kuyo sifike uhleli phandle. Okokuqala ulinde ifayili kuyabanda njenganamhlanje. Yabona namhlanje igodolo egqibeni sothatha itritmenti yam kodwa ndibingathi ndingayishiya ngoba kuyabanda. Kuyatshiywa kuthiwa yibona unika uphela. Ngoba ndigqibele uthatha itritmenti benguMeyi bandinika ipilisi itritmenti ye-3 months. Basibizela enye ingqele ekubeni basinezinye izigulo. Sinethwa apha phandle ngoba kuye kuthiwe indawo igcwale apha kuthiwe kugcwele and ke kuthiwe siyancishwa manesi.
Ekliniki siyafika ufike ekuseni ungafumani uncedo uphethe thina ude uhambe. Mna noma ndidifolthe kayi-3 imbangi uba sidifolthe phofu mna ndidifolthe ngoba kaloku uthi ufikile ekliniki benza bahla benyuka abanika abantu abancedo bahla benyuka and then ke ngoku uthi ngosopha ekliniki upenike uhambe because kaloku senza iijobhu thina. Uyabuya nangoo-3 nangoo-4 ekliniki xa beye ekliniki abantu mababahoye. Zange bandikhansilishe ekliniki ndandibaxelele ngoba waze bandibuza iproblem yam ndachaza uba mna ndisoloko ngumama ndisolokelwa ngutata womntanam so ndihlala ndedwa andiphangeli and then ke zange bandinike i-counselling.
Se re dutse ka mono re palama dikoloi 5 ho ya ho 5:30. 18 re a dula ka nnete re be re bulelwe ho 6:30 re kene re dule he mane ditulong ka hare re dule Ha re ile mane ka di-date tsa rona, ha e le date ya ka kasheko ka di-10. Re lakatsa ka motho ha ilo nka treatment e fela a lokisetswe ka pele. O tla dula ho shape bo 8. Bo 8 ke ona re newang diqepezana tsela, ke ona re ntshang diqepezana tsela ba re shebele di-file ka 8 o'clock. Ha re tswa mono re ya mfuthong mane mo thweng ke mfuthong pontjwang moo. Jwale ha mono che mono ba phakisa mono ka nnete re tswe. Ai mo re dulang ke ka mane mo thweng ke di-nursing. Mane mo o ngollwang dipidisi tsa hao, o behelwa le date e latelang. Tjhe batho he ba dula ka moo. Ka nnete ha re sejeletswe hantle mane ho hang. Nna ne nka lakatsa hore ha ke na le date ya ka ke sa kopane le ngaka, at least ke nke 1 hour ke tswe. Ba nka nako sheba le di-file tsa batho ba bang, utlwe ho thwe hey file ha re bone tsamaya o etsa e nngwe jwang. Jwale o thole hore hey ke sono ka batho ba kulang ho feta. Ba bang re be re ba fetisa feta motho a kulang haholo a fetiswa he ka nnete le a tsamayang ka wheelchair.
Mhlambe ndihambe ndipha ngabo 6:30 kanje ndileke ukugcwala yonke into but ndifika segcwele already. Then sizongena phaya sihlale kumane kuthathwa nga-1 by 1, fumanise uba ke mhlawumbe omnye uyovuselela yonke laa nto, omnye uyotsala yonke laa nto. Then abanye abantu ba-endaphe bengangenanga, mhlawumbe ufumanise ubana kuthiwa sekuleyithi kuyavalwa because iklinikhi andithi ziyavalwa nge-4:30. Then benzelwe khona into eyenziwe phaa istamp, into like stamp kanje, uba then nabebuya the following day kuzofike kuqalwe ngabo. Then nyhani mabebuya the following day kuzofike kuqalwe ngalaba bayizolo. What about laba abakhona namhlanje? And ke bayatravela abantu, khona abantu abasuka phaa kwezalala, bekhona abantu abasuka ngapha kwezalala, bekhona abasuka ngapha bezalala beza kule kliniki eyi-1. So sentsho ubana nje ingxaki esifesene nayo si-staff, phaa istaff asikho, inesi yi-1 and sifuna ke mhlawumbe uba indlela ikhona ekwenziwa ngayo kungezi istaff, kube khona inesi yabantwana, kube khona inesi ezohlukuhla abantu, kube khona inesi ezodila nabantu abathatha i-treatment. Ilentoza istaff sikho, maybe beyingeke ize ibe khona le nto yenzekayo. I-problem kakuhle phaya si-staff, iyona problem ekhona. If ever mhlawumbe uDepartment of Health angenza ngenye indlela into yobana kube khona istaff.
Community stories. So to all of those who have got number 2, please be prepared.
Molweni, mna ndisebenzisa iqumbu community healthcare. The problem noqumbu wethu is just that uyalinda phana.
Greetings. I use Qumbu CHC. The problem at Qumbu CHC is that we wait for too long.
Kuthiwa phana kuvulwa ngo-7 ekuseni, then ke ngokuba thina sihlala ezilalini, we have to use the transport, umzekelo ka-6 ufika kwethu ekliniki.
As I'm using a public transport, I usually get to the clinic very late.
Sifike phana ke silinde ngaphandle, and then ke decide uvula ke ngophangala 7 wabo bamtshoyo, then sisalinde ngaphandle.
They say they open at 7, and when they do decide to open at 7, we still wait outside.
Ulinda kwethu ke bazobiza mhlambe inamba yabantu abayiphandle ngaphakathi bangene ngaphakathi ekliniki.
When we start to work, they only call for about 5 people to come inside the facility.
Ukungena kwabo ngaphakathi abantu abazohoya ngoku bazofike baphinde bafole phana ezitulweni.
And when inside, it doesn't mean that you are going to get help. You're still going to have to wait inside the facility.
Ukulinda kwabo thina sashiyeke ngaphandle, which is ke ngoku dangerous because ikliniki yethu isecaleni kunetawuni, kukho namaphara bafika bexutha ifowuni bathathe imali ezibhajini.
As we are waiting outside, we feel very unsafe because the place is in a secluded place and there are a lot of criminals roaming around.
And then ke ngoku bazohoywa aba bangaphakathi umzekelo bakhangelelwe ii-files. The problem is that omnye umuntu uke yenzeka into yoba yalahleka ifayili yakhe and xa ilahlekile ifault iblenywa kuba nguwe umnikazi wefayili. Suppose into ubuyazi uba uyishiye phi, which is ingazange ize ezandleni.
When we are there waiting inside, they take too long to find the files, and sometimes people get their files lost and they are blamed for the files being lost, saying that it's their responsibility to know the file number and which file they are using.
Which is ke ngoku nami ke yandehlela the last time ndisiye ekliniki bekunge-11 kaSeptember, so ndalahlekelwa yifayili. Luckily for me mna ndandikwazile ukuyishuta ifayili yam ngaphandle.
On the 11th of September, I went to the clinic and I got there and my file was lost. Fortunately for me, I knew my card number and the type of file I'm using, so they helped me.
Then ke ngoku kuba khona umuntu umzekelo ongafundanga, abantu abadala abangakwaziyo nofota ke ii-files, which is ke ngoku xa ilahlekile ifault izoba kuwo, baza kulindisa phana ezitulweni uhlale basevise abanye abantu ke ngoku aba baze emveni kwakho wena uhleli phana.
My worry is there are people that are not educated and do not know the importance of keeping your file number. So it's going to be difficult for them to get help if they don't know their file number.
And then ke ngoku uzothi uhoye ke ngoku bakuse bayomfaxaza bakwenze everything. After that wena usahleli phana ulindile ifayili yakho bathi bayikhangela imini yonke, which is kude badecide uba bavale dispensary baxele ubuye following day.
They take time to start the actual process because you first get to have your vitals taken and you still have to wait, and that causes a lot of delay in the processes of the facility, and the dispensary end up closing, and some of the people end up not getting the medication.
And then ke ngoku nangomso uzophinda ufike ungathiwa kuzoqalwa ngawo since ubulahlekelwe ifayili uzophinda uyofola la line.
And if you happen to lose your file and you are given permission to come back then the following day, it doesn't mean you're going to be first in line. You still have to queue the line.
Injalo ke problem esinayo kwiqumbu, abahoyi bayasilindisa, which is sometimes five yabo emveni koko xa uphinda ungena wena kwenye indawo fanele uncedwe kuyo baxele uba baye elantshini.
And when you do actually get to the consulting rooms for the nurses, they will also tell you that they are going for lunch. So meaning you have to wait also.
And then ke ngoku xa bebuya kulaa lunch bona bayabuya then bathatha iipesi zabo bathi bavalile, then you have to come back the following day.
And coming back from lunch, you still have to wait and they will tell you that they are closing, so they have to go and you are supposed to come back the following day.
And that's it, thank you.
Thank you.
Mna ndiklinika eMatatel Community Healthcare eMatatel.
I use Matatiel Community Healthcare.
Mna ibalam likanje nge-7 kaSeptember ndithatha i-treatment phaya, so bendine-appointment ka-7:30 ekuseni.
On the 7th, I had an appointment for 7:30 in the morning to collect my treatment.
So ndafika phayana ngo-7:45.
At 6:45 in the morning.
Xa ndafika hayi iline seyinde sebekhona abantu sebetyhuwishile, then ndajoyina iline.
When I got there, the line was already too long and I joined the line.
Sahlala ke phaa sahlala, but kwabethu 7:30 kwangaqaliswa, kwabethu 8 kwangaqaliswa.
We waited and it was already 8 and the processes of operation were not started yet.
Then ithe xa kubetha u9 kwafika uSister Sfadi collect ama-card wait for bayobethwa istamp.
At 9:00, Sister Sfadi came and collected the cards for the services.
Then ithe after ke seyecollectile ama-card wabuyisa wathi masihambe siyofutha. Sahamba ke sayofutha noma sagqiba phaa ngabo-10, 10:15.
She came back and told us that we have to go for our vitals, and we went and we came back and waited.
Then ke after lo 10:15 sahlala ke salinda, sahlala phaa liyatshisa ilanga sihleli, asixelelwa noma kwenzakalani, sihleli asazi uba kwenzeka ntoni. Kwabetha 11 sihleli, past 11 sihleli, ithe xa kuyobetha 12 kwabe bekukhona usisi omnye ophangela apha eRitshidze okuthiwa ngusisi Noluvo Jasmine. So wayobuza ke ngokuba kanti sihlalele ntoni singancedwa.
We waited and someone because it's a waste of time to stay in one facility for the whole day.
Kangako, Nkosi.
Thank you.
Nam mandithathe lithuba ndizibulisele kubantu bonke abakhoyo. Mna ndisuka eNgangelizwe Clinic, ikliniki yam leyo.
I use Ngangelizwe Clinic.
Ndizawuthetha izitori zam ziyi-2. Ndizawuqala ndithetha ngesinye ke eseminyaka egqithileyo, but ndifuna nje ukuyichaphazela loo nto. Kwakungo-2014 ndandiyobeleka ekliniki.
In 2014, I went to the clinic for my maternity services.
Yes, ndafika ke kukhona ke omnye ugirl naye oye kwangale situation ndize ngayo.
When I reached there was another lady with the same situation as mine.
Then ke nda-athendwa ke ngamanesi kwathiwa no ndisekude for ubeleka.
The nurse came to me and checked up on me and she told me that I'm still very far to give birth.
Bathe ke mandizulazule ke apha ekliniki kuzele kwenziwe le nto yenziwayo. Then babeka ke izitulo basibekele zona, umntu odiniweyo aze ahlale esitulweni sakhe kungakhwela kweza bhedi sizibeke phaa. Umntu ozokhwela kulaa bhedi umntu ekuthiwe makakhwele.
They told me to walk around the facility and they gave me a chair. So when I got tired, when I get so that I can sit on the chair, but we were not allowed to sit on the bed. They only told us the bed are for those that are ready to give birth.
Ndiyenzile ke loo nto bathe mayenze, ndayiva ubana iintlungu ngoku ziqina ngoqina, ndakhwaza usister uba mabazondinceda.
I went for a walk, and when during the walk I felt the pain was getting severe, and I told the nurse that the pain is getting severe now.
Uzile ke usister wafika ke wandishawuta uba umdala kangaka uqala ngumntana umfundisa ntoni umntana lo uhleli naye kozobe ukhala ubhomboloza umdala ungaqali nokuqala uzala. Uyamoyikisa lo mntana uhleli naye.
The sister came, and when she came, she shouted at me, asking me that as old as I am, how can I set this example for the person that was next to me, which is younger than me? How can I cry at my age?
Wanshiya ke futhi waphinde wemka. Ndaphinda ndayiva uba heyi ii-pains ziba buhlungu wesi ngoku. Ndachwetha lo mntana ulapha ecaleni kwam usisa because ndiyeva no ngoku ndizawudiliva.
After shouting at me, she left and I felt the pain.
Uyile ke umntwana lowo sister, ubuye hamba no sister lowo, wathu sister, jonga wena uzele yakho indawo wedwa, naye uzele yakho indawo wedwa. Hoye yakho into naye hoye yakhe, waphinde wanishiya.
The person I sent to the sister came back with the sister, and the sister came and said to me, to the person I sent, that she should mind her own business. She's not going to help me. I must just go up and down.
Yafika inimba ithi manishiye. Ndaphusha, waphuma umntana apha esitulweni. Ndaphakama ndema ngenyawo. Weza usister, wafika ndithula ndisakhali ke ngoku because ibinditya.
I felt the pain and I felt like pushing and I did push, and the baby came out while I was still in the chair, and then the pain went away. Then I couldn't cry anymore.
Yena ke akayazi uba sendimkhuphile umntana. Undibizile ke wathi yiza, dala ufundekele, sondela.
After she came back, she called upon me saying that I've been shouting and shouting, so I should come. Facility, with the promise that the sister said I should call upon her when I'm in the facility. But when I got there, I didn't see her. I thought maybe she was off. But as the time go by and there is a time I go to the clinic, I realized that she's no longer there.
Ngizobachazela kudala sesele ndingasamboni ke ngosister abantu basekhaya. Wabeke nomntanami ndimbona akukho nto ndibona ingathi wrong.
So I only told the story when I realized that the sister is no longer at the facility to my family, after being satisfied that there was nothing wrong with my baby.
Sabe siphelile isitori sami sokuqala. Ndizongena kwistori sesibini. Ndihamba apha ekliniki, I'm HIV positive. Ndithatha i-treatment phaya. So ndiphaa kwelaa cala le-first lane. Phaa kwi-first lane ke ndicinga uba inoba xa uya phaya ufika nje unikwe nje into zakho uhambe, akho nto ifunisa ubafola.
As a patient at Ngangelizwe CHC, also under HIV treatment and also registered under first lane at Ngangelizwe CHC. From my own knowledge, I thought when you are under first lane, you are supposed to get your medication and leave the facility not less than an hour.
Ndiphume ke emsebenzini ngo-10 ndicelile uba ndiya ekliniki, nyhani ke ndivunyelwe. Ndaqonda uba mandileqe, ndafika kukho oosisi abathathu abafolileyo phambi kwam, nam ke ndafika ndangowesine ndafola. sahlala ndaphuqa mama ke ndibuze pha kubo hayibo kanti akusetyenzwana apha because ukhona umuntu yena ndiyambona but andiyazi into ayenzayo phaya. Nina nifike nini? Bathi ke bona okwethu kudala silapha qha le ntombazana ayide isibize.
I asked for permission at work to go and collect my treatment at Ngangelizwe. When I got there, I met 3 other patients there and they were waiting, so I waited with them. As the time go by, I realized that there was nothing happening. So I asked to them about what is going on. Is there any services? And they told me that we've been waiting here also and there's nothing happening. And I saw the staff member sitting and just doing nothing there.
Sihleli ke phaya into engange-3 hours. Oko sihleli phaya. Ndaqomba ke ngoku mna ke bendicelile emsebenzini selilide eli xesha ndihleli apha. Ndiyakhalala ndiyahamba mna. Babe besithi naba sithi hayi nathi ayikho lesihlelele apha. Ngoba le ntombazana ivele yaphuma total ke ngoku. Ayabikho kwakule ndawo. Oko ibimkile akho ne-excuse ayitshoyo.
So we waited and waited, and it was over 3 hours now, and I panicked because I asked permission from work. So I decided to leave the facility because I saw there were no services going on.
Ndabe ndiyahamba ke ngaloo mini ndingayifumananga itreatment. Lilonke ke ngaloo mini zange ndibe ndiyayisela ipilisi ngobusuku. Ndazophinda nge-following day. Ndizokuncedwa ke ngosuku olulandelayo. Sendincedwa ke ingekho laa ntombazana seyenye ke ngoku ephe efestileni.
So all in all, on that day, I didn't take my ARV pill. I went home and I got to the facility on the next day, and I got to be saved on that day. And the person that was sitting there the day before was no longer there.
Ndincome ke kule yesibini intombazana cause zange ndihlale. Yayile nto ndiqhelileyo nam uba xa ukwi-fast lane ufike unike ipasela yakho uhambe. Ndancedakala ke ngolo suku. Iphele istori sam.
So I would like to appreciate the staff member that was there on the following day because she showed me what it means to be on fast lane, as I did not wait for too long when I got there the following day. Thank you.
Thank you. Thank you. I will go to recommendations, comrades. But before I go to recommendations, listening to the stories or testimonies from the community, we must all of us, including community members, the officials, ask ourselves, what makes our government not to be able to provide adequate services if the budget is there? We know why. About 60% of the budget does not go directly to purchase services. It goes to pay for medical legal claims because of cases like the ones that are being reported here. I saw in Nelson Mandela Metro at Doranginza, healthcare workers' unions are toying, demanding for an increase. But I have not yet heard any trade union of the healthcare workers condemning the conduct of other healthcare workers on how they treat communities. Mr. Somayela, leadership of the PHIV sector and all of us, the department, we need to engage with unions. Not only about a salary increase, but also how do we engage with them so that we can sensitize them in clinics. Because at the end of the day, not all nurses are bad, but there are those who are doing these wrong things. How do we sensitize them in order for them, one, to respect the constitution, two, to adhere to what is on the patient's rights charter? Gateway Clinic, Tata Gateway Clinic, Gangelizwe CHC, Nozuko Clinic, Ngamakwe CAC, Port St. John's CHC, Umbu CHC, St. Patrick's Gateway Clinic, Stanford Terrace Clinic, Solo Clinic, Willowvale CHT, and Kocha CHC. By February 2023, open the grounds of the clinic by 5 a.m. to ensure safety of public healthcare users waiting to access services in the early morning. By April 2023, extend facility opening hours as per the National Department of Health Secura from 5 a.m. to 7 p.m. on Monday to Friday. People living with HIV should be able to use these extended opening times to pick up their antiretrovirals. By 2023, April, appointment system should be put in place, including appointment times to ensure efficient service delivery and to reduce waiting
Ndandiyile ngangelizwe ekliniki because ndandigula.
So I come from Tata. I use Ngangelizwe CHC. Last year I went to Ngangelizwe CHC because I was feeling sick.
Ndandinefiva ndigodola.
I
Ndavuka
had-
ekuseni ndaya ekliniki engangelizwe nxa ndifika phayana wathi unesi ndamxelela unesi bana andikho right ndinefiva, so wathi unesi akazukwazi ukundinceda mandiqale ndiyothesta. Then ndizothi after ndigqibile uthesta andincede.
I went there, I had fever, I was feeling cold. When I met the nurse there, she told me that she can't help me without me taking a test for an HIV.
Ndafika ke phayana ndangena nxa ndifika ndafika kukho nesi abayi-3. Oyi-1 ngulo wayendithesta endinceda, so wandithesta. Fine, nxa efika
I went to the consulting rooms. When I reached there were 3 nurses in one consulting room. One of them was the one that was assisting me with my test. So I did the test and went to the other nurse.
wathi ke ukundithesteni kwakhe wafumaneka ukubana ndipositive. Kobo bupositive bam akazange andixelele ngendlela erayithi. Wathi kumsisi itshayile ngoku. Ndaqale nam ndothuka. Emva koko ndothukile ndababona abasista abayi-2 sebehleka. Wathi sisi ndithe upositive. Abelila ke.
Me that I should go. And she further said, if I don't take my HIV treatment, it means I'm going to die.
Ndazixelela ubana never ndiphinde ndiye ekliniki ndose ndicele olunye uncedo. Zange ke ndaphinda mna ndaya phaya ekliniki. Ndagqibela ngoko ndandiyile.
From then on, I decided to never go back to that facility ever again. I opted for sending someone instead of me going to the facility. And even today, I'm still not going there.
Thank you.
Thank you.
Thank you, comrades. Uthixo woxolo nothando uyakungweba if ndingavela ndifunde apha kukho ingxaki. Mr. Somayel, leadership of the HIV sector. Kudala sithetha, kufuneka senze umzekelo. Comrade Sibongile, Rev Boyan, so nonke maqabane slow nangu comrade Mr. Somayel. We need to take up that case today. Go to that clinic. Make sure that we get that nurse. Comrades, we sitting kuma 8 councils. We cannot be sitting there whilst there are problems on the ground that we are unable to resolve. We need to make an example about this. Oh, comrades, I sit in higher structures where these presentations are being made about missing people and that and that and that. What is not being said in those presentations? What is the reason for people but decide ukungayi clinic bothatha treatment yabo? I-blame ibekwa kuthi. Sibe thina i-reason singayi clinic zimeko that we are experiencing in those clinics. Si decide ukungayi clinics because of the attitude on us to a level where we end up dying. And the blame is apportioned on us as people living with HIV. Blame is being apportioned on us as key populations. So this thing of talking must come to an end now. Leaders, we need to take this matter. We need to present this matter. We need to bring this matter to the attention of the MEC and the Superintendent General so that an example can be made. If kungenziwa umzekelo ngonesi neclinic A1, bonke will learn from that. Abantu bayeke uhlukunyezwa eziclinic. Something must be done. Let me go to the recommendations. And isasebenza le mic yami. By October 2022, all public healthcare users should be consulted in private rooms. Privacy violations, such as being consulted, tested, or cancelled in the same room as someone else, can lead to people living with HIV disengaging from care. By April 2023, the Eastern Cape Department of Health should fill all remaining cleaner vacancies and employ additional cleaners at the 28 sites reporting shortages to ensure clean facilities and toilets. By October 2023, where there are small waiting areas that leads to overcrowding, meaning putting people at risk of TB, the Eastern Cape Department of Health must implement interim strategies to address these infrastructural issues, including building temporary structures, as well as decanting more people living with HIV out of the facility to external pickup points or community-based attendance clubs, and implementing 3 to 6 month supply of antiretrovirals. Over to you, Comrade.
Thank you. Now the next set of issues are on antiretroviral treatment collection. This can be abbreviated as ART or ARVs. So the revised National Adherence Guideline Standard Operating Procedure note that time constraints are a challenge to many people living with HIV, and as such, efforts should be made to support people living with HIV with suppressed viral loads to receive extended refills and or be enrolled in a repeat prescription strategy. Implementing this is vital to supporting improved long-term adherence. Unnecessary trips to the clinic just to collect ARV refill can contribute to people living with HIV interrupting treatment or disengaging from care altogether. Ritshidze data reveals that while there has been a major improvement since last year in terms of extending ARV refill length to 3 months supply, with 34% of PLHIV interviewed reporting 3 months ARV refill. This is just below the national average reported by Ritshidze and compared that also requires investigation, considering that South Africa's national policy standard is for 2 months. However, only ensuring that 34% of people living with HIV are receiving a 3 to 6 month supply is low in comparison to other provinces, and very low in comparison to other PEPFAR-supported countries who are implementing multi-month dispensing much more rapidly. For example, While 61% of Ritshidze responded in the Eastern Cape still receive refill of less than 3 months, only 20% of PLHIV in other PEPFAR-supported countries had refills of less than 3 months. Between October and December 2021, in 21 PEPFAR-supported countries, 44% of people living with HIV received 3 to 5 months ARV refill, and 36% received 6 months supply. South Africa is far behind most countries in terms of maximum duration of ART, both as a national policy and as a COVID-19 adaptation. Repeat prescription collection strategy can simplify and adapt HIV services across the cascade in ways that both serve the needs of PLHIV better and reduce unnecessary burden on the health system. 53% of people living with HIV interviewed collected at the facility's standard medicine dispensing, with 21% collecting at the facility pickup points, 12% using external pickup points, and 3% using adherence club. From interviews in April to May 2022, 100% of facilities reported having facility pickup points, and 89% have external pickup points available to decade stable patient too. In order to be effective, repeat prescription collection strategy should make ARV collection quicker, easy, and more satisfactory for people living with HIV than waiting in long clinic queues. Out of 153 people living with HIV interviewed, 96% thought extended pickup points made ARV collection quicker. And again, 95% of PLHIV were either satisfied or very satisfied with the external pickup points. This is positive and shows that pickup points are working. Out of 268 people living with HIV interviewed using facility pickup points, 94% thought they made ARV collection quicker, and 85% of people were either satisfied or very satisfied. It is important to ensure that as many clinically stable, it is important to ensure that as many clinically stable PLHIV as possible are voluntarily enrolled in repeat prescription collection strategy that suits their needs. Once enrolled, reassessment should take place at each clinical consultation to understand if PLHIV are satisfied with their pickup points or adherence clubs. PLHIV who are not satisfied should be offered a different option that better meets their needs. In addition, once enrolled in pickup points, every effort should be made to keep PLHIV active in their chosen model with facility when due. Out of 1,270 people living with HIV interviewed, we have 53% we spoke to that wanted to collect ARVs closer to home. So we should be voluntarily decanting more people living with HIV to external pickup points and community adherence club, which are closer to home.
nto bekade kuyiyo kubuyiswe ezaa pilisi sizithathe kwezi ndawo besizithatha kwezisondelele. Ndithatha u-HIV, ngupressure, iswekile. Ivalo lothi ndiyaye xa ndizifuna iingxelo zam xa senditsalile njengoba nditsala kanye ngonyaka ngoku. So ndiyanixelelwe ke ngoku uba ivala lodi yakho isahamba kakuhle. So yonke into yakho iseme kakuhle, akwabi nanto iphuma caleni.
Ndiklinika kule kliniki yaseMqanduli. Phayana into abavele bayenze xa bethetha nam bavele bathi ndiyadika. Ndibe ndingazazi noba ndidika entwenini. Bendiqomba ndirhalela nongazithathi nezo pilisi. Zezi pilisi zipinki kuthiwa zii-ARVs. Ndiye ndifoliswe. Kanti mna kuye kuthiwe mandingafoli phayana. Bendifanele uba andifoli. Suke ndiyothatha nje iipilisi ndiphinde ndiphume ndihambe. Ngoko ndiye ndibone uba ngamanye amaxesha andifili kamnandi. Futhi ndibonakala ndingonwabanga. Ndiye ndizibone uba yeyi ndiyahlukumezeka gqithi. Kuba kaloku ndiye ndibone uba andilindelanga mhlawumbi uba ngumntu omdala lo befanele uba uthetha kanjalo kum. Ndibe ndiqonda uba yeyi uba ngaba bekuthiwa kukufitshane eXhorha bendizawuya khona. Bavele bandingxolise nxa ndibhude ideyithi. Ndingayibhudanga loo deyithi leyo, ndingalandi ukuba vele bagqibele ngam, baqale ngabanye abantu. Bavele bandishiye bahambe baye elantshini. Ndishiyeke ke mna ke ndisalindile phaa, ndibe ndishiywa lixesha ke. Baye bathi qha ngemini ethile bazawunditsala amagazi. Bangandixeleli ke ngokuba abuye esithini loo magazi wam. Bendingekababuzi, qha ke ndiyaboyika babuze. Ndiye ndiqonde uba andifirishi ukuya ekliniki. Qha ndiye ndicinga uba ndibethwa nje yimeko yoba mandiye. Yeyona into ndingathanda sisi uba batshintshe ukwenza apha kuthi, bayeke uthetha noba kukanjani. Ngoba kaloku thina esingabanye siyakhawuleza ukhathazeka. Phayana uba ndiyile, ndiye ndibone uba ndiye ndiphume ndikhala inyembezi.
The community stories, I believe it's all of the number 4s.
I'm Jonguxolo Mzinzwa. I come from Flagstaff.
Yenda ne problem yokuthi ndinikezwe idate yokuyolanda iipilisi. So ndibe setawuni ngalo before that date. Ndiyozenzela igrocery yasekhaya. Ndathi mandisoze ndidlule apha ekliniki.
In the past 2 months, I was given the date to go collect my treatment. So I was sent from home to go buy groceries. So I decided to pass by the clinic to collect my medication before the due date.
Into abangixela yona ekliniki bathi ayisiyo date yam idate yakho. Idate yakho yazi nge-14th, yi-12 namhlanje, so that ufanele ubuye nge-12. Kungenjalo hlala phaa esitulweni. Ndigcinisile kulo yegrosala, iyo date yam ndiyayazi loo nto, qha bendiyikhawulela idate kuba sendilapha kufutshane.
I was told today is not my date, so I should wait in the queue or come back on another day, which is the 14th, the due date for my appointment. I told them that I went to go buy groceries, so I decided to come and fetch my treatment. do as the
Waye wathatha ifayili yam wahamba waya nayo phaa uthathwa khona medicine wandizela nee-pills zam ndaphuma ndahamba.
The nurse that I met with on that day attended to me and she took my card. I went inside and came back with my treatment, so I went home.
Ndathi ke xa ndibaxelela ke ndiphuma e-treatment room ndabaxelela ukuthi bendicela bandenzele ifeyiva ngoba andinayo imali yokuza ekliniki manje. Bandinika noba ngamapilisi e-2 months or 3 months ngoba imali endispendayo xa ndisiza ekliniki yi-R110 so that ngamanye amaxesha ndiye ndingayi-afford.
So when I got to the dispensary after the nurse helped me with my card, I got to know that they were giving me only 1 month supply. I suggested to them, asking and pleading with them that they should give me at least 2 to 3 months so that I will not come back to the facility each month. I also told them that I am not employed and it cost me 110 rand to come to the facility. So if they could please give me at least 2 to 3 months.
Ndizocela lapho kwi-organizations nizivakashele ii-clinics ngoba i-treatment i-unfair kwii-clinics esizisebenzisayo. Uya ungakhubekanga uphume ukhubekile.
So I'm also pleading with the organizations present here today that you do really do visit our facilities because we do not receive better treatment or better services at our facilities. And you find that you go there being in a good spirit and come out there very wrong. So we do plead and urge with you guys to visit these facilities.
Ndiyabulela ke ngale organization endithenda kuyo ndiqala ukuzapha eMonti namhlanje. Ndibulela kakhulu lo organization leyo.
So, because I am now in East London and it's my first time coming to East London, I thank you very much, organization. I would like to thank the organization for giving me this opportunity to come to East London as it's my first time coming here.
Man, 1, 2. Mandibulise mkhaya lethu kaKolisile luthethayo. Ndisuka eZibeleni.
My name is Kayale Tukolisile. I come from Ezibeleni.
Ndiklinika eNomzamo Clinic.
I use Nomzamo Clinic.
Ndiyenye imember etya treatment e-ARVs.
I'm on HIV treatment.
Nge-3 kaOktobha ndifumene i-call esuka ekhaya kusister wam endizemva kwakhe esithi khaya kufike imoto apha ka-Department of Health izokothula ii-ARVs zakho apha endlini ndizisayinele.
On the 3rd of August, I got a call from home. My sister called to inform me that a vehicle from Department of Health came to deliver my HIV treatment at home, so she signed for it.
Ndaqala ke ndothuka ngoba ekhaya zange ndidisclose. Only usister wam apho ndidisclose khona ngulo ndihlala naye endlini.
I was so surprised because I knew that at home I didn't disclose my status, so they didn't know that I was taking ARV treatment.
And ngeli xesha kuzi treatment ne-treatment yam endiyityayo esekhona ngoku.
And by the time the treatment came, I was already having a treatment that I'm already using at that moment.
Kusuppose ndiyokolekta i-treatment yam ekliniki nge-20 kaOktobha, meaning this week.
I was supposed to go for collection on the 20th of October, meaning next week.
but ne-treatment eyothulwe nge-3 ethi yona i-treatment mandoyikota nge-11 ka-October le yothule kusister wam.
But I have a treatment at home that was dropped off on the 3rd of this month, saying I should go collect another treatment or next week.
Xa ndisiya kusister wam ndiyoqiniseka le treatment ndifike endlini wandibuza umbuzo uba umntakwethu u-HIV na.
When I got home, I got a very big question from my sister and it got me scared. She asked if I was HIV positive or not.
Qala nomama wothu
And my mother got shocked also.
kwanyanzeleka ndidisclose.
I was forced to disclose.
My sister ke ungumntu abuser i-alcohol kakhulu.
My sister is someone who abuses alcohol too much.
Ukusuka lo mini uza namhlanje kodwa noyinqanda kuyo ndikhwaza nge-ARVs.
So from that day till today, I can't say anything to her because she shouts at me and insults me with my HIV status.
Loo nto ke nditraumatize kakhulu ngoba ndihluthele ilungelo lokugqibela ngurhulumente lokundisclose without i-permission yam nokundiconsult.
I'm very much disappointed because the department has taken away my right to disclose on my own for my HIV status.
Tusho into yokuba ngoku today andisekho kwifolder ethatha i-treatment yam. Kusuppose today 20 ikule veki ndine-message endixelela clean efowunini uba endikhumbuza bazothatha i-treatment yakho ngeti 20 ayikatshongwa ayikabikho ngoku nto ichaza ukuthi kudibhaleke ekliniki uba ndidisclose ndiyadefault.
And as evidence, I usually get an SMS on my phone to go for collection at the facility. As a result, that SMS has not yet come in to show that my medication is indeed delivered at home.
Xa ndigqibezela loo ndifundise into yokuba ukhosi lam kwi-situation where at a facility bathi udefaultile yet he has not defaulted. How do we fix that? A few weeks back, Mr. Somayel, a Motherwell, a patient had an appointment. He went to the clinic. He was insulted by the nurses. Inside the clinic, the patient went back home to fetch his firearm. Straight to the clinic. That's why NU11 clinic is closed. Because of the attitude the nurses gives to the patients or to the communities. Not all of us are the same. Guess what? Now the blame is being apportioned to the community member for the actions, for his actions. Nobody is saying anything about the staff attitude. Nobody is saying anything about that. And nobody wants to take irresponsibility of sensitizing the nurses on how to talk to us. Because the nurses, when they talk to us as if they are giving or doing a favor for us. No nurse is doing us a favor here. No nurse or an official of government that owns government public health care institutions These institutions belong to government and they are meant for the people. Everybody in this house and in communities don't want to go to clinics. Why should the nurses be paid? Why should officials be paid? Because they are not rendering the services. We need to discuss about these things. If it means, as people living with HIV, we must go to union buildings, sleep there until the state president and minister attends to us, we are more than prepared to do that. The fact that we are doing this, Comrade Thandukolo, it does not mean that we are no longer having the guts to take it to the streets. And when we take it to the streets again, we are not scared, comrades, but we want to work together with government, agencies, and everybody to fix the problems on the ground. But if these problems continue to be like this, we will reach a stage where we will be like, we cannot take it anymore. As the Mezelkin, can we please try to fix these problems before we get there? The recommendations, comrades, are as follows. From October 2022, the Eastern Cape Department of Health, Match, and TB HIV care must ensure every stable person living with HIV is offered repeat prescription collection options. People living with HIV enrolled in RPCs must be active, not overdue for RPCs rescripts. On the program, PEPFAR to monitor and report on people living with HIV enrolled in RPCs that are more than 28 days late for rescript by facility. By April 2023, the Eastern Cape Department of Health Match and TB HIV care should extend and implement ARV refills to at least 3 months supply for eligible people living with HIV. By end September 2023, the Eastern Cape Department of Health Match and TB HIV care should extend and implement ARV refills to 6 months supply for all eligible people living with HIV. Before I give to you, Ndivu. Okay. The Eastern Cape Department of Health Match and TB HIV care should continue efforts to restart and re-establish adherence clubs in the province in order to provide people living with HIV with options for quicker ART collection together with peer support and treatment literacy. In Country Operational Plan 2022, the Eastern Cape Department of Health Match and TB HIV care should scale up implementation of repeat prescription strategies to reach 90% of stable people living with HIV and ensure 60% are accessing treatment from community models, meaning external pickup points and community-based adherence clubs, and 20% from group-based models, such as facility community-based adherence clubs. It must also be noted that people living with HIV should be able at more convenient locations for people living with HIV. Before I give to you Ndivu, last month, the national leadership of people living with HIV had a meeting with Dr. Buthelezi, the Director General. And in that meeting, Dr. Buthelezi told us that they have approved a policy as the department of a 6-month supply of ARVs. We do not know whether that policy has been communicated, Mr. Somayela, to provinces and whether provinces are implementing that. But I think it is the responsibility of all of us, including myself, to reach out to the Director General and ask them to communicate this to provinces so that it can be implemented. Thank you.
Thank you, GS. We're now going to touch on issues around art continuity. People living with HIV lead complicated lives and may well miss appointments and even miss taking some pills. When they do, meeting them with support when they return to the clinic helps to ensure long-term adherence. Yet poor staff attitudes and unwelcoming services remain a key challenge that mean people living with HIV have stress and anxiety about going to the clinic or stop going to the clinic altogether. Staff attitude remains a major barrier. Across facilities, out of 2,473 respondents, only 55% of people thought that the staff were always friendly and professional. This has worsened since last year, where 63% of people thought that staff were always friendly and professional. The Eastern Cape is performing below the national average on this indicator as well. Many people we spoke to had never missed a visit to collect ARVs. Out of the 355 people living with HIV who had missed appointments, 27% said that the staff were welcoming when they came to collect ARVs if they had previously missed a visit, and 34% reported that staff provide counseling on adherence if you return to the clinic. However, 25% said that staff send you to the back of the queue the next time you come in, and 14% said that the staff would shout at you. It's also important to note that Ritshidze interviews take place at the facility, and therefore these numbers do miss people who have already disengaged from care and are not in the facility, some of whom we'll hear from today. The table reveals the clinics with reports of people being sent to the back of the queue if they miss an appointment. According to the National Department of Health, this is not required, and the new Welcome Back campaign actually states that people living with HIV returning after a treatment interruption should be triaged in separate streams instead of being sent to the back of the queue. This graph also shows data across time with steady improvement in staff attitude since data collection began in the province. However, there's still a long way to go to ensure all public healthcare users and key populations are treated with dignity, respect, and compassion at all times. The department, MATCH, and TB HIV care must implement welcoming services to ensure that all people living with HIV, as well as key populations, are able to start and stay on treatment, including people returning to care. 403 people we interviewed in Ritshidze have been denied access to services for not having a transfer letter across 40 facilities since we started collecting the data last October. This represents 16% of all public healthcare users interviewed, but given that most people interviewed are unlikely to have attempted to transfer services, it continues to point to a much larger problem regarding the communication and policies regarding transfer letters. All sites should be investigated. However, in this reporting period, we are particularly concerned with the following sites, which are Pilani NU Clinic that had 50 reports, Komposi Jabavu Clinic that had 35 reports, Empilweni CHC that had 26 reports, Zanempilo Clinic that had 26 reports, Duncan Village CHC that had 23 reports, Letitia Bam CHC that had 16 reports, and Palmerton Clinic that had 16 reports. Again, it is important to note that Ritshidze interviews take place at the facility. Therefore, people who've already disengaged from care due to challenges associated with the transfer letter would not have been at the facility for us to interview. While results are not heterogeneous across a district, the department should investigate to assess if these are province-wide challenges, as well as investigating each facility individually that has been listed. Once again, as a reminder, that transfer letters are not required in the guiding principles of the re-engagement SOP, which states that if a patient comes from a different facility, transfers in, do not require the patient to provide transfer documents or delay restarting treatment as per procedure in 2019 ART clinical guideline. We also have about 502 patients who were interviewed by Ritshidze who had been denied access to services for not having an identity document across 38 facilities over the last year. Again, it's important to note that these interviews were conducted at the facility and not within the communities. Therefore, people who've already disengaged from care due to challenges of a identity document would not have been included or would not have been interviewed. Psychosocial support is a critical element to ensure long-term retention. So when people living with HIV disengage from treatment for any reasons, clinicians need to be sensitized and attempt to expect a normalized treatment interruption. This way, the narrative between people living with HIV and clinicians will be less punitive and more supportive. Ritshidze data shows that 85% of people living with HIV interviewed in Eastern Cape do know about psychosocial support and it being available, and the province is performing based on this indicator. The Eastern Cape Department of Health and PEPFAR district support partners should ensure that the remaining 14% of people living with HIV are also aware of support services that they can access. In addition, once again, while the Eastern Cape is performing based on this indicator, full packages of psychosocial services are not yet available at every clinic. A full package of services should include provision of individualized quality assured counseling to patients, peer-led patient navigators acting as a bridge between clinicians and patients, mapped networks of referral services, optional support groups, and food parcels. As part of psychosocial support, support groups should also be linked to each public health facility that are critical to provide counseling and support services to people prior to testing, post-testing, pre-treatment, and those struggling on treatment or re-engaging in care after a treatment interruption. Treatment literacy improves linkage and retention rates as people understand the importance of starting and remaining on treatment effectively. We're finding that 95% of people living with HIV whom we spoke to had gotten a viral load test in the last year, and positively, 90% of participants reported that they knew their viral load. In this quarter, 89% of people living with HIV agreed with the following statement: having an undetectable viral load means the treatment is working well. And 85% agreed with the following statement, that having an undetectable viral load means a person is not infectious. This has improved dramatically compared to last year's report, when only 72% agreed with the statement having an undetectable viral load means that the treatment is working well, while only 67% had agreed with the statement having an undetectable viral load means that a person is not infectious. The Eastern Cape performed second best on our treatment literacy indicators. Positively, 91% of people living with HIV reported that a healthcare provider had explained the results of their viral load test result, which is up from 79% from last year. The department and DSPs must continue to ensure that healthcare people living with HIV did not fully understand what an undetectable viral load means, that treatment is working well. So these include clinics in Alfred Nzo, Imzizi, Isigelo, in OR Tambo, facilities like Palmerton Clinic, in Nelson Mandela Bay, Letitia Blam, CHC, in OR Tambo, clinics like Flagstaff Clinic, Flagstaff Clinic. So these are facilities where the department can also go in and start making investigations or trying to understand why patients are not understanding issues around treatment literacy. And once again, at others, even more people did not understand that an undetectable viral load means that you cannot transmit HIV. So again, the department and DSP should investigate and ensure that these sites offer adequate treatment literacy and viral load information during health talks and during people's consultations as well. Going to move into our recorded stories now.
Mna ndingumhlali eWaterfall. Ndithatha i-treatment engangelizwe. Khona igame endandingazange ndiphatheke kakuhle. Makutheni ungabuyanga ngedeyithi ethile? Ndathi ke mna ke hayi mntanam bendingayazi. Wathi hayi mama, xa kuthiwe buya ngayo ubuya kuba mhlawumbi zoko uzawutsalwa amagazi. Xa ndifika edispensary athi unomizana othile phaye andinike i-treatment lo nomizana. Yathi ndingekahambi wandibiza wathi mama ndicela uze kum. Ndaya wathatha i-treatment yam. Wathi kutheni na ungatsho uba i-treatment ubuyinikiwe eye 2 months. Ndithi ke mna ke ndize ngedeyithi ebekuthiwe mandibuye ngayo, wayithatha i-treatment. Ndathi okay sisi, iipilisi ebendinazo mna ngoku ziphelile, that's why ndibuyile. Ndicela undisayinele apha ekhadini lam kubhalwe red. Ndithi ndicela undisayinele apha ekhadini uba uyithathile i-treatment. Athi yena andizukwenza loo nto mna, i-treatment ye-2 months ubuyinikiwe. Bane-attitude, at least amanesi abhetele. Ingxaki isikakhulu iba kwabantu basedispensary. Kaloku kwakukho apho sizawubaripota khona, but ngoku siyavuya xa nikwazi ukungena ekuhlaleni nimane nitshekisha. Kona kona edispensary abakwazi ukuphatha abantu kakuhle. Kona kona abantu basedispensary kuyafuneka befundisiwe ngathi ukuba mabasiphathe kanjani.
Ikliniki endihamba kuyo yingangelizwe. I-treatment endiyithathayo phaa engangelizwe yi-ARVs. Awuyanga laa deyithi yakho, uye nge-following day. Into abaye bayenze phayana bagqibela ngani nina niyibhude ideyithi. Kugqitywa aba bebenedeyithi yabo. So ke yinto endingayithandiyo ke leyo because uhlala phaa imini yonke ulambele phaa. Ufumanise uba uyobuya ngovo. Ndadlulisa i-2 days, ndaya kusuku lwesithathu. So kwaxa ndifika phayana bandithethisa uba bazondiqalelisa ngoba ndiyafana mntu odifolthileyo xa ndingazuhamba ndingazuyazi ideyithi yam.
Ethatha i-treatment ye-HIV eklinikini ePaarl. Ebethatha i-treatment khona uthe nethi asebenze aye emsebenzini. Emsebenzini bekungavumi uba makathathe i-treatment kuba itshansi ibingekho emsebenzini. Abelungu abathanda umntu ungekhoyo emsebenzini. Kwaze kwala kwinyanga yesibini ndahamba ndaya ekliniki. Apha ekliniki ndiyofuna i-treatment. Phaa ekliniki kuye kwathiwa ndikhwalifaye phayana eStanford. Ndikhwalifaya kwenye ikliniki eMthatha. Ndaphinda ndabuya ke apho ekliniki ndingayifumananga i-treatment. Ndaya kwikliniki yesibini eGethawo. Apho ndiye nalapho abavuma undinika i-treatment. Ndaphinda ndahamba ndaya eNtaphane. Phaa eNtaphane kulapho ndiye ndaphatheka kakuhle, ndazifumana iipilisi zam endizifuna. Isizathu soba banganiki iipilisi bafuna ndize netransfer leyo ndingakhange ndaba nayo. Hayi ibingekho, engenayo kwanto. Khange ndiphathe kakuhle noko, khange ndizive mandi apha ngaphakathi entliziyweni yam.
Ikliniki hospital eButterworth. So into ebangela ndibe kufutshane yiloo nto uba ndiyitya i-treatment yaphaa because bathi phayana mna ndine-TB. So ke ngoku ufika kwam phaa esibhedlele ke bandizama ngetreatment ngelaa nyanga ndandifike ngayo. Zaphela ezi, andithe xa ndiphinda ndisiya phaa kwathiwa ze ndiphinde kufike kwenye inyanga yesibini ezayo ndize kwenye suku. Andaya kwenye isuku but into ebangela uba ndithi no ndiyakhalaza kuba iyi-1 apha ngaphakathi yaba ndiyakhohlela ingathi ndikwinto endihlabayo. Ayikabikho kona phaya ndagxothwa phayana kwakliniki ndiyoyithatha kwelaa xesha bethe mandiyothatha itreatment. So ndaya phaa ndiyothatha itreatment kodwa mandifike nesimens kodwa bandisikele laa nyanga. So mfana uthi no bra ilwela kwinto yakho wena inizima uphinde uzapha xa kuphela ezi pilisi. Ndabe ndisithi bhuti mna bekuthiwe nantsi ideyithi. Wabeyibona ideyithi yiyo qha ke ngoku ndibekela engeyakhe. Ndathi mawulani uba zenqena uthetha naye kakhulu. Ndathi okay akho ngxaki mandihambe. Ngingazama ukuya ekliniki kanti into ezandibetha kuhamba.
Ke ile ka ya tleliniking Matatele community ne ke yo hula madi mokgwa teng ke motho a nkang treatment fela ka mohlankono ka February early February ne ke yo hula madi ne ke sa lata treatment le teng madi ana ne ke tlamehile be ke ile ho lata ka January tlasa mosebetsi ile ya feta January ka ya ka February itse ka nta ke fitla tleliniking ke ile ka thuswa ke sister eleng sister Jafta ke ile ka kena ka phaposing ya hae itse ha ke kena ona sa batle lo nsheba mahlong ke kene ana le attitude ke ile ka dula stool a lokisetsa ho nkala o ile a re ke mone file ke ile ka mone ya file itse a qeta mone ya file a re ke January yo o tlang ka yena ke ile ka mo araba ka re sister mosebetsi hanga ba ka qeta le ho bua o la re ke mosebetsi monna ona o sebetsang o ka ba wa tloela o tlatla hula madi ka date ya hao a re hona ke salary nna yona eo o e fumanang ho mosebetsi ke ile ka theola meokgo o la nka file ya ka a ngola a ba re tswa o dule ka mona ka ntle line ke ile ka tswa ho no le teng ngwananyana na dutse pela ka o ile a nqhwaya a rausi sister ye wa o tseba ke ile ka re a ntsebe o ntsebella mona tleliniki a re jwale ha sa o jwetsa ka ntho tsa di salary ya hao kena ka ka a di tsebe ya nna tsamala ene o fihlela ke ba ke kena jwale se ke disetsa ho ka tla hula madi ile ka fihla ka dula setulong ne ke nkile file itse ntse ke dutse setulong o la re bega pha ke ile ka beya file tafoleng a re a nthanga o beke file beka ingalo ugqiba ungavina lapha emadlebeni ke ile ka utlwa bohloko ke ile ka phama ho sona le ba bang bo sister ba dutse tafoleng itse ke phama bona ke ntsha meokgo a re ungade ukhalele ngokuthi ungazi ngoJanuary ukutsala amagazi ke ile ka mo araba ka re sister mantswe ya hao bana ba bang ke ile ka thola go ba maketse ba le siko ho etsala tsena ke ile ka tswa ke lla ka tleliniking ka be ke tsamaya itse ha ke ya ke shebile stadiumong sa Makhalad ke ile ka kopana le mo sister wa Mohlankana ke ile ka ya ho yena a itswela mo itswela ka re abuti ha o na le mathata tleliniking o sa thusahala hantle o etsa ha jwang a ba re o ya ho sister Mtoto kapa sister Sefadi ausi ine se kgetlo la o qala ka nako tse ding rena le ntho ane hore re nelehetse o nka ngwana kapa o nka mme wa hao ha ile date ya hao a yo latela treatment ha o ile wa roma ngwana o tlela ka story ha o ile wa roma motho a moholo ne ke ka roma motswadi wa ka atla a sa batle letho a ngwana ka ke ya metse tleliniking se ke kgetha ho ikela hobane jwale ba tla ba lla ka ho se tshware hantle tleliniking ba shautwa ntho tse jwalo bohloko ba shautelwa ntho tse bang ha ba di tsebe bona ba roma ba o lata di sitsa rona tlasa hobane rona re batho ba sebetsang ho ebang ke na le ngwana lapeng mang le yena o ja treatment ka le leng ona ka tlolwa ke date ke matogo a re mokoko ke kopa o ntatela le ho ja date intlotse o nahane mo ka le kgale ngwanaka a re seng ke yo tontlolwa mane ke ba tseba le monga dipidisi le yena o a tshaba hobane o a tseba na o tla kopana le ba bang ba e ba end up ba se ba sa di late dipidisi ba se ba sa yi tlasa o tshaba re ya re tshwere mmele tleliniking ya ausi.
Kliniki e ke e sebedisang ke kliniki ya Maluti. Before ne ke sebedisa kliniki ya Matatiele, so kliniki ya Matatiele ba re change ba re tla kliniking ya Maluti. Ai treatment ya teng ha e tshwane le ya tropong gore the way ba re tshetsang ka teng ha o tshwane le tropong. Tropong ha o fihla le dula ka site la lona like ke batho ba HIV ke batho ba nang le tswekere ke gore di diseases like tsena tse serious. Maluti le ba mix up o kopana fela le a le nka dipidisi o kopana fela ke batho bana ba tshwereng ke mhlomo o tshwerwe ke sefuba then re kopana kaofela hemone ba line e telele. Ntho e ke sa e ratang ya Maluti e one kore enka e mentiona ha o fihla mane mo yo nka dipidisi teng ke dispensary line ya teng e telele and the line ya teng e le telele ka 3:30 ho a kwalwa o tlameha go sane o tlo tlang ka dipidisi wa di fa ona tsona dipidisi o tlo robala o sa nwa treatment ya hao. Engwe ntho hape excitabeleng ka kliniki ya Maluti manese a teng a bohale haholo ha o fihla mane ha o tlamele motho a bue le wena hantle ha o bue le wena hantle o tla ba o rofa and ha o qeta ho tswa ka mona ka mo sebeletsang ka teng motho a tlo kena a ke re o bone ha o tswa motho a tlo kena o tlo tsamaya mona kliniking a sa tseba information e nngwe le nngwe ka wena because ba babedi ka mona ka woteng then ba tla be ba ntse ba bua ka gore wa mona motho la qetang ho tswa o entse tje ka mokgoleng se hole ka teng o etsa tje ya bana ntse tse jwalo ya ha ke ya kliniking ke ya palama ke sebedisa transport is 22 rand o tlo mona ya kliniking 22 rand ho kgutla which is 44 rand. Ntho ba kgutlisetsang yona sometimes most of the time mane dispensary he ba go kwetswe then o tla khutla o sane he tlamelo sebedise another 44 rand hape o khutlele o lata dipidisi tsa hao. Engwe ntho hape e be ba e bui ba re o fositse date ha o la fosa date wa ska khona ho ya ka date ya hao then ha ba khutlisetsa but ha o la fosa date ba tla isa morao then na kwana o sitswe morao o tla bo a ke go sitswe morao then o be late jwalo o ska khona ho kena dispensary then o tlame o khutle ka la osana ho ba ha e tshware hantle ne because ho etsala hore manese I2 una le tafole engwe e mane then ho be le engwe e kang e dutseng ka nqena then wena ha o kena o tlo ya ho yane le kena le two e motla kena a ye ho sister ene mong wena o ye ho yena ka nqena so le consult ka nako e one o etsala hore o ntso dutse mane tafoleng le wena tsebe ya mamela ke o mamela dintho tsa yana ka nqana ya bona so I sharp at all for privacy ya motho because ka go ka bua le sister yo o buleng lena kana go ngona le ntho batlang ho bua le sister le two fela ha o khone ho bua jalo wa utlwa re le 4 ka mo ka weteng ha o khone ho bua ka se khone ho bua o tlo bo o tsontsona le ntho bothata bo bo tshwereng because ha o qeta ho tswa bana le ntho ana go ba about discuss o le siko but ho le teng engwe patient la ka etsala nna ona ntho patient engwe e qeta ho tswa nako ke dulang fatshe ke ntsha di-file tsaka be ba discussa patient e qetang ho tswa which is ke bona ke o ya bona hore ha ke bone le ntho e right at all ha re botse in fact nna for my side ha ke so botse like ha ke botse because o suka o a ba tshaba a se batho ba bang ka khona o bua lena ga sister ke na le bothata maybe kopa o tla ba o jwetsa hore thetha ka lo xa ngafuna uthetha uphume khona umuntu ofuna uthetha apha yabona ufuna ukungena apha okanye o jwetsa hore yena o ya lunching nako wena o se ra se sa batla bua yena wa tsamaya lunching go manesa a Maluti ka ra ka ba le botho a khona nanela motho yo mong tingata hampe ntho tse ka di buang ho bona gore hanka o fa mhlala fela one day I was there ke le mo kliniking then ha ke qeta o dula fatshe hona le nkgono e mong ana tlile le ena tlong ka treatment ya hae and then sister ana a mo thusa nkgono a fositse date a sa tla 2 days before, so nkgono na ba mo jwetsa o na bua seXhosa o mntanami ndisikwa kude, so ndicela ufane undincede ke ngoba andiyibonanga iphepha lam, so ke tlile 2 days after because akuyabona nantsi pen wa tseba ne ke tswe moo ke sa thuswa because ke la buela nkgono ke la nkwa ke maikutlo ka kenella conversationeng ya hae le nkgono enwa a re a kgutle hosane because o fositse date ya ba ke re ausi wa mmona na nkgono enwa mo kae, nkgono enwa o sebedisitse tjhelete ya hae, maybe o e kadimme ha makhelwane for a tlo tlatla mo tleliniking, so wena ha gore a kgutle hosane, which is it's a wrong thing in your gore a kgutle hosane o sa le mo tleliniking. Re hula ka thata, poverty is too much in South Africa, so mme maybe o kadimme tjhelete ya ho palama, a qeta o kadima tjhelete ya ho palama e re a sa le mo a kgutlisetswe back morao ho thwa tle hosane, it's a wrong thing. Ke re ho ausiana if ha o mo thusi then nna ke tlo tla nka tech ya hao, ha ke na taba le hore na ke tlo founela radiong or ke tlo ya mara ke tlo batla hore kgone a thuswe, so ntho la ntsha mane bala o ko bonela ka re ba ya o skima ba o kopanela ba re ke bua haholo then
ke dula hanchodu ke nka treatment maluti, so ntho e sa nkgotsofatseng maluti ka ho fitlile late o tlo tsamaya late tleliniking, okay fine ha ba fast ha o fitlile late tleliniking ba tle be ba etsa hanyenyane, ha ba ile teng ba ya nako e telele, but ntho e sa ntshwareng hantle hape ke ha o sa ya ka date ya hao, ha o sa ya ka date ya hao ba tle be ba o jwetsa hore o zomela aba bantu ba lapha le ba ho fitlile ba bang ba fitlile ka morao mohlomong ka bo 3:45 o tlo emela bona kapa o kgutlele ka la hosane hape tleliniking mpane o palame ka tjhelete hobane ke dula hanchodu ke palama ka 18 rand ha ke sebetse, bo fitlile ka 7 ke tsa mohlala kapo 8 o tlo dula o emele batho be bang a ke re bona ke di date tsa bona, o emele date tseno then ibe o tlo emela 4 ha nka ba 4 a shapile sentse ba sentse ba kwala ba tsamaya ba be ba o jwetsa gore le kgutle ho sa ba tlo fa dipidisi tsa hao, ba re ngole mane re ngole dintho kore mava a rona hore rona na re rena empaneng ha ntho re bonang e qobeleyang ha ke tjho jwalo ha ntshware sharp hobane ke tla be ke kadime mohlomong tjhelete ya ho ya ke tlo pheta hape ke nke ka enngwe.
Ne ke ile tleliniking ka di 8 tsa kgwedi ena fedileng, ka be ke putile date mo tlamehile ke ile ka di 7 batho ka ba ke fihle ke putile date o tla qetelwa ka nna ka nnete ba re thusa ya se ba fedile batho mpano bo qonba o fihlile o se mohlomong ka bo 7 ka nako e nngwe tjhelete e ska ba siko e be le tjhelete e bang ha e tena o sa e ka date ya hao ka ba ke re sa ikadimo re tseba hore re ye tleliniking ho bona ha ba putile date ba bang batho ba e bang ba ile tleliniking ba qeteletse ba tsamaya morao ka baka la rona ba bua hampe ho fihla ba o shauta ba o ise le dintho ba o ise kae ba be ba go ye ho counseling.
Okay mfundisweni ndiklinikhi apha emfundisweni ekliniki, ndivuka ekuseni ndiye ekliniki nditye i-treatment ye-HIV at the same time ndikhulelwe, so bengade ndiklinikhi apha ke akuhoywa, sifike ekuseni uhambe wanywaatyanga phaa ko-6 ufike xa zifika iinesi zifika zingcole evrandini azinihoyi ebule kubethe oo-9 akaqala usetyenzwa uyagoduka angasebenzanga. Mna ke ndike nda 3 days ndijika ndingagcoli treatment and ke nasendike ndayidefaulta ke kwipilisi ngoba kaloku ndiye kwanye iintsuku zibe yi-4 qonda uba ndisayi. Last month ndiye kwadwa kwathatha and abantu oonoba bahambe bethetha ngezi-status zethu okanye ukhulelwe, umntu uzohambe ethetha ngabo uba hayi ndimthestile utheni, akatyi treatment, uyidefaulta. So nje iinto ezinjalo nje ayindiphathi kakuhle ngoba kaloku kungoku bendikhulelwe ndayokuqala ikliniki ndiniyose ukade phofu bengandizicela ebantwini bazixele uba umntwana ke ngoba uzoafektheka ke. Neenesi azikho iinesi, hayi noba phaa uyatshekha awusiwa kwi-counselling, awukhanselwa nje. Kwezinye iikliniki uyokhanselwa xa ufumanisa ubu-H_I_V positive, uthini hayi apha ukhanselwa, unika iipilisi zakho ubuyahamba. Uba okanye awufumaneki ifowuni umntu uzoya kuwe aye emzalini okanye uyayifihla kona ke ebantwini abadala yabo, awufuni uba wazophi utya iipilisi. Kodwa nantsi befikile umetshi, ewe ziyalithatha igazi zibuye ii-results but ungachazelwa ukuba kutheni i-viral load yakho. Like le ndawo i-viral load beyivele konyusiswa ube zithatha eGoli, kubakho into eyi-viral load nayo bengazi iindaba za-viral load. Abasixeleli nto, ufike nje umntu amnike into then abe seyithula amnike, fakwe ekhadini lakho.
True story sam esase-village clinic yalapha eLusikisiki. Mna ndandiye ekliniki ndiyopreventa. Since ke ikliniki akunakwa, sime ilayini okokuqala ixesha elide, sime phaa ngaphandle sitshiswa lilanga, akukhoyo. Singene ke sesingenile ngaphakathi, kunosisi ongunesi but andimazi gama lakhe, omfutshane, onamabele amakhulu, odla ngoba phaa kulaa ndawo yokubhalisa. Aphinde azoshawuta wena, athi ngosekushawutile uphinde athi esuka bheka umntu ole ecaleni athethe nomntu osecaleni angathethi nawe. Sometimes ude uhambe ukubuza kwalapha abantu abalapha ekliniki uba indawo ethile yephi ngoba woyika uphinda phaa kwasi sozokukhwazela ngoba uyakhwaza. Uye kwaba zokunika isitofu ozotofa ngaso, uzothi ungena bonke bajonge kuwe. Uzotofa nganti, uzotofelani umncinci kangaka? Sowucinga ukwenza le nto sofuna ukutofa. Sanje eminye imibuzo uvele uyibone uba ayidingi ukubuzwa. Watofa, uthetha nonesi oyi-1 kodwa babayi-5 endlini bonke naye bengangeni indawo ubungezanga kuba bazozothetha babuze uba and baze bakukhethele uba andizukunika idepho, fanelanga utofa ngedepho, funeka utofe ngenara. Nomzekelo idepho inara indivumi, indisa kwi-periods the whole month kodwa bona bayakwazi ukukunikeza isitofu ungasifuniyo. Nabanye, mzala ulapha nawe kondilandele, amlandele umzala. Uzothi sobona ngomzala uyaphuma kodwa ebele ngemva elayinini, nanku umzala seyiphethe i-handbag yakho uyaphuma, unishiya apha elayinini nina. Basuke bathatha iti ye-2 hours, nihleli nina apha. Oko nihleli kobetha oo-4 kude kuvalwe ekliniki bufike ngo-7. Mna i-treatment ngiyiqale 2018 ye-HIV ye-ARVs boost. Then ngingazisebenzisa ngendlela erayithi kuba ngisasebenzisa nangoku. But this year, I think bekusaqala unyaka, bangitshintshela ilanto ze-treatment, banginikeza i-treatment yasekuseni because mna all along bengisebenza yasebusuku. Why betshintsha mhlawumbe bangixelele banike reason yobana so andikazi I know ndisebenzisa treatment ndiyidla ngendlela erayithi but ukundixelela oku into endiyifuna uba ndizazi ubana ndiqhuba kakuhle nangobona ama-result wam, yayibo. Mhlambe ama-side effect into ezinjalo hayi Qha ke ngayisebenzisa kodwa angaze ngive into erongo emzimbeni wami, angaze ngive into.
Hayi mna ndandithatha i-treatment phaa eNozuko. Ndayeka i-treatment ndithatha eGateway. Phaa asitukwa thina zezanesi zaseGateway njengasenozuko klinikhi. Hayi ngase bayeke uthuka abantu, urabesha abantu ayizozinja. Hayi kaloku ubufike ekuseni kaloku phaa eNozuko. Xesha bendisathatha phaa mna. Ubuhamba phaa ngee-past 3 xa kuzovalwa. Okanye past 2. Bayamodelisha phaa kwezaa passage ngezaa chops zabo.
Treatment aphi emsobomvu. Emsobomvu so andihoyakalanga. Ndiphele nam sendibaphendula ndithi njani kaloku. Andithi nipeya nje kungenxeni yethu. Siza kuhamba phi ikliniki xa singazuhoywa nini. Bathi ayikho niyakuthanda nokugula. Bekutheni ningasebenzisi ikhondom. Ndibuze ke mna into xa seyenzekile yenzekile. Sizoba sathini? Ayondlela yokuthetha, abakwazi uhlala nawe phantsi. Funeke xa bethetha, funeke bekushawuta makuve wonke umuntu uba ngoku uzela into ethile, busokuhlela inyanga ezikanga. Awuhambi ikliniki, ubizwa yonke into nje. Ndonqena uthuka mhlawumbi nina nizuthanda. Wonke umuntu makabone uba nasi isipoponi, uphuma nesipoponi. Ngoba kwenye igame ndizinceda ngoku besizinceda ngokuphatha ipesi. Ayindimandi yedwa ukhona wesibini othetha le nto ndiyithethayo. Umuntu abenofana noba ideyithi uyitsebile, afike akunike ntoni treatment yakho yodla endlini. Angabi kuthethi sebekujongisa. Sesiphele sithoka nazo iitshomi zithi nje. Zithi wena siyakwazi ukumdaka une-HIV.
Now we're going to go to the community stories. If we could have all those who have number 5.
Ndiyabulisa ngaphakathi, nam ndingumhlali walapha eMdantsane kwa-1. Mna ndize ekliniki, apha ekliniki ePhilani, ikliniki eNyuwani. Ndifike ndiyivizitha from ePaid. Bandinika iipilisi zam, ndi-HIV positive. Ndithatha itreatment yobu-HIV positive. Bandinika iipilisi okokuqala, bandinika okwesibini. Osogqiba
Okay. I'm a resident here in Mdantsane. Is it NU1? It's NU1. I got here by transfer, and I was I'm on HIV treatment.
ndeza okwesibini xa ndiphinda ndisiza okwesibini bathi bafuna i-transfer letter.
When I came back the second time to collect my treatment, it's only then that they asked me for the transfer letter.
Ndathi ke ngoku mna xa ndafowunela ePaid. Iipilisi andazinikwa, kwathiwa mandize neekhonteyina zeepilisi endizityayo, ndize ngokwam ne-transfer letter, andazinikwa iipilisi.
So my children were not given the treatment, and they were told that they should tell me that I should come and also bring the type of container that I'm using for the treatment.
Ndiye ndacela kusiso senext door kwam kuba ndiyonqena uba ndingatyi ezi pilisi. Ndathi kuye ndicela andiphe iipilisi okwangoku. Nangoku ndisatya iipilisi ebendiziphiwe nguloo sisi. Bakhange ndizinikwe ekliniki.
So I had to ask from my neighbor to borrow me some of her pills so that I can continue with my treatment. And even today, I'm still using the treatment that I got from my neighbor.
Siswam, asikwazi uphuma apha. Siswam, asikwazi uphuma apha ungayifumenanga i-treatment yakho. I ask Mr. Somayela and other officials to deal with this matter today. Today, you must get your treatment. If Mr. Somayela must call someone, zikhona imoto apha phandle. We can drive you to the nearest facility, you get a treatment, you come back with your treatment. We're not gonna tolerate that. Something must be done now, today. Thank you.
Mna ndisuka eNozuko Clinic eGcuwa. Izitori zam nazo phaa kula kliniki zininzi.
I come from Nozuko Clinic in Butterworth, Ecuwa.
But ke namhlanje ndizothetha ngesi ndaphantsi kofa ngaso.
I have too many stories about that clinic, but for today, I'm only going to talk about the one that I had a near-death experience from.
Ngo-2020, I think bekungo-October, ndaye ndaya ekliniki. Ndabe ndine 2 days ndingayanga ekliniki. Ufika kwam ekliniki ndifike around 6 because kuyavukwa xa kusiyiwa kulaa kliniki.
In 2020, I think it was around October, I went to the facility and I got there around 6.
Then ndafika ke ngoku iinesi ziqala ngo-8 usebenza mos. Ndafika ndahlala ekliniki ndalinda u-8. Ngo-8 bafika, ufika kwabo ngo-8 inoba bendingowe-5. Kwathiwa ubana mna ndizobekwa ekugqibeleni because idate yam andizanga ngayo. Andamayinda ke ndaqomba inoba yipunishment yam.
So when I got to the clinic at around 8, when they started to work, I was number 5 in the queue and it was not my appointment date. So they told me that they are going to serve me last because I missed my appointment date.
Ndahlala ke bandinceda phaa ngo-4 ndaphuma ekliniki. Ndahlala. Then last year ndatya treatment yam bandinika zonke izinto. Then last year ke ngoku ngoJune ndiye ndaziva ndiphefumla kabuhlungu. Ndinomthambo, ndiphefumla kabuhlungu. Ndahamba kobe kuFriday ndahamba ndaya kwagqirha. Omnye woogqirha baphaa eGcuwa uya kwam kwagqirha wandinika ugqirha izinto zondinceda. Then wabuza, ndamxelela ke mna ukuba gqirha ndikwi-treatment ke. Wathi ke na ke ubana ze ndiye ekliniki Monday.
So last year, on that day, I got the services at around 4:30 and then I went home. Last year, as I was continuing with my treatment, I experienced pains in my chest. So I had to consult a private doctor. I even informed the doctor that I'm on treatment and the doctor referred me back to the facility.
Ndaya ke ngoku ekliniki eNozuko. Bathi ubana bekufanele ubana ndiye ndaza nezinto ebefanele uba ndincanyathiselwe kwelaa khadi lam. Of which ugqirha phaa xa uye kugqirha akho nto uyinikwayo eli khadi eneza barcodes bazoklikha ngazo phaa then ndijongwe phaa uba lezi zinto bendizithestelwa ndinantoni. Ndabe ndibaxelela uba nakakufunyaniswa uba mhlawumbi ndineCOVID okanye ndinantoni. Bathi bana mandize nezaa results. Andaza nazo ke mna ke. Ndahlala phaa ekhaya ndaphinda ndagula. That's serious.
So when I went back to the clinic on the referral from the doctor, this is a told that I need
Then ke ngoku i-treatment ndiyifumana kulaa mama. Andiyazi ke ngoku uba njengoba after 3 months umuntu umane kufuneka ehambe ayotsala amagazi uba ndizawatsala njani because andifuni uya kulaa klinikhi and abakuniki i-transfer. Andifuni ube ndixoxa nabo uba kwathini wena wayefrefre safowunelwa. Andifuni loo nto. Enkosi.
Thank you.
Asiyeke sithando.
Mna ndingowase
Yisondeze.
mna ndithatha i-treatment ethatha engangelizwe. Ndandiyothatha i-treatment yam. Xa ndifika andayifumana kwathiwa ayiyo date yam. Ndayeka. Ndadifoltha unyaka. Ndagula. Emva konyaka ndahamba ndaye engangelizwe ndayoyithatha. Baye bandenzela. Ndandisoyika uyoyithatha ndicinga uba bazawuphinde bandingxolise. Baye bandenzela bandinika ndiphinde ekliniki ngoMatshi 2022 nge-2. Bandinika i-treatment yam zange bathethe. Ndirhalela benze loo nto kubo bonke abantu. Enkosi.
So I come from Mthatha. I use Ngangelizwe Clinic. Last year I was taking my ARV treatment, and once I got there, I was not helped, and I decided to not go back to the clinic. So when I decided to go back this year, back to the clinic, they helped me well, and I was not shouted at. And I would like to commend and also promote that they should do this. They should treat all other people the same way as they treated me.
Mna njengoluleka Zwelithile sebenzisa iikliniki eziyi-2. Umntanam ugonya eJabavu, then mna ndithatha i-treatment yam eCentral. Ndifike eCentral ndikhulelwe ne.
Okay. I am Fikile. I used 2 clinic, which is Jabavu and Central. I use Jabavu for my child, and I collect my treatment at Central.
Ndifike ndikhulelwe eCentral, then bandinika i-treatment. Bandenza zonke izinto, then bandinika i-treatment yam. Babuza uba ithini into yam, ndibaxelela, then bandinika i-treatment yam.
I arrived there being pregnant, and I told them that I am on treatment, and they gave me my treatment.
So ndiqhubekile phayana ndithatha as i-visit phayana. Ndade ndayobeleka pha eCentral Clinic. Then ke ngoku kobuya kwam nomntwana baphinda baqhubekeka bendinika as i-visit bengekandivuleli ifayili.
Okay. I continued as a visitor at Central until I gave birth to my child. And even after the birth of my child, when I switched my child from the clinic that I was using, they still continued serving me as a visitor there.
So xa ndibuyela ke ngokweli cala ndiyothatha i-treatment ngapha kuba ndingasathathi kweli cala ke ngoku bendihlukuhla kulo, uyothuka laa nesi uba andizange ndivulelwe ifayili ndimxelele mba okokoko babendinika as i-visitor. Athi akazukwazi undivulela ifayili andithatha andise kule nesi ibimane ndinika i-treatment as a visitor lonke eli xesha.
So this one time I met with the nurse, and while she was consulting me, she saw my card and she was surprised that for this long I was not given a file, or the file was not open for me. So she decided to take my card and go back to card that was signing on my behalf so that she can open a file for me.
Intombazana endisuke kuyo yandiphika yathi ayindazi, azange ndahlukuhla phaya, akhange ndijongwe nguye nomntana.
ndithathe ikhadi lomntwana ndimbonise ndithi jonga apha ndiphele ndiyomgonya umntana eJabavu because wena uthe izigonyo azikho mandibaleke ndiye kwikliniki endofumana kuzo izigonyo. Ndithi ayinguwena ebesayina apha, athi hayi inoba leyo ndim but andikhumbuli mna ndikunika itreatment kule ndawo ndibhukishwa kuyo, kube nzima naye undenzela i-transfer party abe surprised into yobana okokoko ndathatha itreatment phayana andizange ndadefaulta. Athi uzobhala nethi into ethi ndithi bendihlukuhla phayana. Why bengakhange xa bendinika iipilisi babhale nto? Why bebemane bendinika iipilisi qha kungabikho nto isayinwayo phantsi ebonakalisa uba ewe ke bendithatha phayana? Afane andenzele ke i-transfer olo hlobo, then ndibuyele back kubo bandivulele ifayili ke ngoku.
So during that conversation, the end result was that I should go back to the clinic that I was using before to get the transfer. And as I did go back to that clinic, they told me that that my results are showing as if I'm defaulting there. And I agreed with them, telling them that it's been a whole year not continuing or not collecting my treatment from this clinic, but I was collecting from the facility that is requiring a transfer for me. So when I told the story to the person that I got to meet at the other clinic, she decided to give me the transfer, not wanting to argue and talk further about the issue.
Then esangapha ndise umntwana ezigonyweni. Xa ndifika umntana ose-reception athi ucela i-ID yomntana. So mna ndihambe ndiphume ekliniki ndiyothatha ikhadi endlini. Xa ndibuya back nekhadi ndimnika ikhadi abuze uba alithini ikhadi, I mean i-certificate somntana. Athi asithini i-certificate, ndithi hayi uthe ufuna i-ID yomntwana so i-ID number ilapha. Athi khange ndithi mna ndifuna certificate somntana ndithe ndifuna i-ID number yomntwana. Ndikrweco lileyidi lisecam kwam ke ngoku lindicacisela uba ebesithi mandiyobhala i-ID number endlini.
So when I got to Central at the reception, the lady there, when I got to Jabavu at reception for my child services, the lady at reception told me that she wants a birth certificate for the child. And mistakenly, I went back home to get the birth certificate. When I came back, she told me that she did not require the birth certificate, but the ID number of the baby. And I was quite confused, and the reaction I got from her and the attitude I got from her, it was not satisfactory.
Then ndiphele ke ndibhala i-ID number yomntana apha ekhadini. Xa ndibuya ndimnika ikhadi lam athi akazukwazi undinceda. Ndithi hayibo ngoba because ndibhalile i-ID number lo buyifuna. Athi ke yena ke ondikhubekise gqithi uargüisha nam ntontontonto. Ndiqonda mandimshiye evutha ndifune usister in charge. Usister in charge asikrweco sobayithu asibizile kwelinye igumbi.
So during that conversation, she ended up telling me that she's not going to help me because I showed her attitude, and I ended up going to find the sister in charge of the facility, and we were both called into the office so that she can talk to both of us.
Ufika kwethu kwelo gumbi ngoyena ke uye wageza usister in charge because uye wathi kulaa mntana, ndandithe kuwe, this is a pen. Watsho igximfiza phantsi uba beka le phantsi xa ugezelwa ngumntu, awuzange uzogezelwa apha ntontontonto. Ndimxelela isitori sam sonke ne. So xa sisoba kweli gumbi ngoku usayida nalo mntana aphele geza laa sisi abe okay ndithi kuba ndiqonda uba andifuni ithethisayo ndithi okay bani igama lakhe ndizoxela uxolo. Hayi kuleyithi ngoku azoba sacela uxolo serongo gqithi naye lo mntana ke ngoku alile because ubona ebhekhapha ngulo sisi. Alile lo mntana then ndiphele ndiphuma phandle. Xa ndiphuma phandle kuthiwa andizuncedwa ngulaa mntana, sawufunela omnye umntu ozandibhalisa because serongo gqithi lo mntana.
So in that conversation with the person in charge of the facility, I got to notice another thing, that the attitude from the receptionist and the person in charge is still the same. They are both agreeing on the bad attitude that they are servicing me with, and they ended up telling me that they are not going to help me, so I should go outside.
Ungena phaa ke comrade anele laa mphu walaa bhuti. Nam bendinomphi ngena ndiphumile ndiyothatha umphu because ndiyagezeleka ngoku.
There was a gun also.
Thank you. Thank you. Before I can read the recommendations, I believe all of us here, including myself, when we are dead, Fundiswam, we want to go to heaven, not to hell. I want to go to heaven when I'm dead. But the question I'm asking, how do we turn our clinics and our healthcare facilities to be a heaven, elangazelelwa ngumuntu wonke, instead of by clinics zethu ibe sisihoko? Because akekho umuntu xa eswelekile ufuna uya esihoko. Now our clinics they are becoming like isihoko, where vuka you know a clinic xa ndibuya hleze ndibuye umphefumulo wami usukile ehlalweni. But also, as the department will be responding, the other thing the department must advise us ngayo into ukuthi, when you are at a clinic and then you've got a complaint, you want to lay a complaint, where do you lay the complaint? Don't tell us about complaint box. Please tell us about the new system, because na babahlali, they know ukuthi that complaint box does not work. It does not work. We need to come up with new ways ukuthi how do we report complaints that clinic level. But I cannot report usister Ndivuwo ku-anele yawo babe bezi colleagues and expect justice for a patient. These are colleagues, they work together. How do we make sure that kukho enye intervention yomuntu or outside to avoid le ndaba yemipu? Also, as the department is going to be responding, the department must tell us what plans are they planning to put in place in the event we are a clinic, you miss a date yakho uthunyelwa ngasemva elayinini. Because if the department does not issue a circular, Tina as activists and people living with HIV, we will tell what people must do. If the department is not stopping this in clinics, Tina, we will tell people, ukuthi, if you are being turned at the back of the queue, now you need to apply activism. You are going to say we are closing clinics, yet we are fighting for our rights. You need to do something about that as a matter of urgency. Lastly, before I read recommendations, yabo comrade Thandukolo, if maybe you are banking with Capitec or ABSA, you can go to any Capitec in South Africa. Your name is there. ABSA, we won. Why would you not see that in the department? Why a piece of paper, a referral letter? If akunayo, kuxoxe loba uncame ubomi bakho usweleke because of a piece of paper, ube umbona umuntu nanku. We need the department to assist us in addressing these things. Reason being that, comrades, we fought for treatment to be where it is today. 2004, nabono loyiso sadutyulwa efrontier. Silwela for abantu abaphila with the HIV to access the treatment. We fought against uManto Chabala Msimang. We fought against uThabo Mbeki. And it can't be true ukuthi ngoku treatment ikhona but abantu basasafara and they don't get treatment. Something needs to be done as a matter of urgency. Our recommendations, comrades, are as follows. The Eastern Cape Department of Health, Match, and TB HIV care should implement with fidelity the 2020 standard operating procedure on national adherence clubs. All staff should be trained and held accountable to provide a friendly and welcoming environment for all public healthcare users, including key populations and people living with HIV returning to care after a late or missed scheduled visit. Silent transfer from another facility or treatment interruption. Overall accountability should be with facility manager if no improvements are made. Healthcare workers must acknowledge it is normal to miss appointments and or have treatment interruptions. and support and empower people living with HIV to improve retention after re-engagement as per the 2020 standard operating procedure. Any reports of poor staff attitude should be urgently investigated and disciplinary actions taken where appropriate. For facilities Ritshidze reports on, the Eastern Cape Department of Health should respond within 3 months with actions that have been taken to address all the reports that were reported. No person living with HIV should be sent to the back of the queue if they miss an appointment. This is not a National Department of Health policy. The Eastern Cape Department of Health should send communication to all sites withdrawing this measure and highlighting the welcome back campaign strategy that says people returning to care should be triaged. The Eastern Cape Department of Health should issue communication that highlights that people living with HIV who return from treatment interruption but have not missed a dose be screened for immediate access to a repeat prescription collection strategy. Any reports where immediate treatment continuation or restart is delayed by healthcare workers requiring a transfer letter should be urgently investigated and disciplinary actions taken where appropriate. For facilities Ritshidze reports on, the Eastern Cape Department of Health should respond within 3 months with actions that have been taken in those facilities that have been turning people at the back of the queue. Lastly, from October 2022, the Eastern Cape Department of Health match and TB HIV care should ensure that all healthcare workers, including community healthcare workers, provide accurate and easily understandable information on treatment adherence and the importance of an undetectable viral load when talking to people living with HIV through consultations, counseling, outreach, and health talks at clinics. I thank you.
The next group of issues are based on key populations. One major barrier to HIV prevention and treatment services for key population being discriminated against at the facility. Of the 674 key populations we interviewed in the Eastern Cape, many were not receiving services anyway. 47% of gay, bisexual men sleeping with men, 41% of people who use drugs, 39% of sex workers, and 47% of trans people. Of those who were accessing services, the majority used the public health facility to access their health services rather than a drop-in center, mobile clinic, or private doctor. 71% of gay, bisexual men sleeping with men, 80% of people who use drugs, 86% of sex workers, and 70% of trans people. Yet, at clinics, key populations are often treated very poorly by the clinic staff, who at times shout or verbally abuse people, questioning people's sexuality or gender, and how or why they engage in sex work or take drugs. Other reports being humiliated in front of other healthcare users. Some key populations have told us that the ill treatment has been off-putting enough for them to prefer to go without ARV treatment or other health services. Due to these challenges, KPs had low satisfaction levels in using public health facilities. KPs reported poor treatment and unfriendliness from the clinic staff. Only 28% of respondents reported that the facility staff are always friendly and professional towards gay, bisexual men and men sleeping with men. 37% towards people who use drugs, 29% towards sex workers, and 57% towards trans people. Clinical staff were most commonly reported as being unfriendly and unprofessional by all key population groups, followed by the security staff. Key populations were also concerned about ongoing privacy violation as clinical staff were known to disclose people's HIV statuses, or the fact that they are KPs in front of other healthcare users, or to invite other clinicians into private consultations in order to mock or judge people's symptoms. Services provision must be respected the privacy of the public health users as inherent in the patient's rights character. However, Ritshidze data highlight that the significant number of key population do not think that the privacy respected at the clinic. 25% of gay, bisexual men sleeping with men, 33% of people who use drugs, 35% of sex workers, and 39% of trans people complained that their privacy is not well respected at all facilities. Fear are simply not available at the facility, or key populations are questioned for taking them or refused access. Ritshidze data in 46 facilities show that the lubricants were only available in 41 of the sites in the reporting period. Data collection among key population also find low availability, with only 41% of gay, bisexual men sleeping with men, 18% of people who use drugs, 26% of sex workers, and 29% of trans people using the public health facility who said they could access lubricants. Condoms and lubricants should be available at all facilities and can be easily placed in toilets or other areas of the clinic where people could take them without fear of being seen by others. It is well known that the oral PrEP is highly effective for preventing HIV transmission, as it allows people who have HIV negative to be controlled of their HIV statuses, as much as it is a vital tool to support HIV prevention, especially among key population at a higher risk of getting HIV. However, despite this Ritshidze data that PrEP is not always made available to key populations in facilities, PEPFAR committed to ensure that the key population who tested HIV are either linked to HIV treatment services or PrEP. However, our data challenges in implementation of commitments. Positively, interviews with facility managers revealed that PrEP is available at all 45 facilities, regularly monitored by Ritshidze. However, the number of reporting PrEP of key population low for each KP group, gay, bisexual men, 24% of sites. People who use drugs, 11% of sites. Sex workers, 20% of sites. And trans people, 9% of sites. Further of key population interviewed, only 36% of gay, bisexual men sleeping with men, 24% of people who use drugs, 26% of sex workers, and 43% of trans people. Reported being offered PrEP at the facility, having on site, but not educating people on it, and offering it to those who could benefit will ultimately not improve uptake on PrEP services. Harm reduction services are critically important to support people who use drugs to stay alive and protect their health, including ensuring the accessibility of methadone and unused needles, overdose treatments such as naloxone, as well as psychosocial support and information safer for drug users. However, on the whole, these services are not available. People who use drugs are not often judged and treated in a hostile manner. Ritshidze data shows that the 36% of people who use drugs we spoke to wanted to access to methadone. 15% of people who use drugs we spoke to wanted access to unused needles. And 35% of people who use drugs we spoke to wanted access to overdose treatment like naloxone. Services accessibility must be improved, ensured that the needs of people who use drugs are met, and no additional barriers are created to being able to take drugs safely or to be supported to stop. The availability of gender-affirming services for those who need them, critically important, in addition of psychosocial impact of gender dysphoria. In the context of South Africa, a country with so much transphobia and attacks on trans individuals, excess hormones therapy could mean a life or death. But gender-affirming care is mostly only available in big cities. Trans people who live in rural areas, provinces without any gender-affirming care must travel long distances to these sites get their services. This keeps out reach of without access to transport, money, and places to stay. 29% of trans people we spoke to wanted access to hormone therapy closer to home at facilities. Further, 43% wanted outreach services for trans people. 71% wanted trans-friendly STI prevention, testing, and treatment. And 14% wanted mental health services. When we ask the facility manager if they provide key population-specific services in some places, they say they do. However, when we probe further into specific of what services are provided, it is apparent that a few facilities provide the specific services needed. For example, out of 42 facilities managers we interviewed, only 5 facilities reported offering PrEP for gay, bisexual men sleeping with men. Only 7% facilities had lubricants. For people who use drugs, out of 42 facilities managers interviewed, only 4 facilities reported offering a referral for methadone initiation, and only 3% had a vaccination diagnosis or treatment for viral hepatitis. Out of 42 facilities managers interviewed, only 5 reported offering contraceptive for sex workers, only 4 facilities reported offering gender-based violence services for sex workers. Out of 42 facilities managers interviewed, only 2 facilities reported offering outreach services for trans people. Only 5 facilities reported offering psychosocial support for people, for trans people, while PEPFAR and the Department of Health have committed to establish, to designate sites at or centers of excellence per province This is entirely inadequate to meet the needs of their key population. The province is vast and the key population is everywhere. A minimum package of key population specific needs should be made available to meet key population specific needs. At least 2 designated sites per district. These facilities should be highly sensitized to the needs of the key populations and provide friendly, safe, and conditional services where key population needs specialized care for one of these public health facilities. Easy referrals and adequate resources, including transport or cost, should be provided to ensure uptake of these services. Thank you.
So now we're going to move to the community stories. All of those who've got number 6.
Hello, everyone. My name is Sive Ngalone, and I will be just briefing you basically on my journey. I'm not going to drag it or anything like that, now. So when I started my hormone journey, I went to this other hospital called Dora Nginza Hospital, which is in Port Elizabeth, right? That was like my first time, well, not first time, first year when I started my hormones, and I didn't know where to start, to get help. So I went straight to Dora Nginza, and that's when I got there by the receptionist, and well, there was a female lady there, right? Sorry, a lady. She was helping me out with the filing. So there's 2 files, right? There's a blue file and there's a pink file. So the I started going on, but no, you can't do that to me. I mean, my ID it says exactly what I am, and I've went through so much for that ID to be changed just for you to disrespect me like that. I will not lie, guys. I went on and I did tell him exactly what he wanted to hear. Now. And then at the end, well, they filled in my information in a blank paper, which is it was not a pink file nor the blue one. They filled it in fine, and then I asked them, well, they directed me to this other doctor. I don't know the doctor's name, I forgot her name. So I went to the doctor. Well, that problem was sorted, right? I got disrespected, and it was just it. I don't know how they ended, which file they ended up using between the two files. But anyways, I went in, saw the doctor, and then, well, they told me there in Doranginza that they don't provide any services for trans women specifically, because this is not the facility where I can get such help from, right? And but the doctor started giving me all challenges, and started actually to explain all the things that I will be going through as a trans woman. Remember, that was my first time ever going on this journey, and she completely briefed me with everything that I needed to know, and I was grateful for that. But then she referred me to this other doctor, which was in Livingston Hospital. That was 2019. And then after that, I just decided to end my day because it was so bad from the receptionist, and I didn't report it to anyone at Dora and Ginza Hospital, because I felt like it was just ignorance basically in our community and within Black people, well, people in general. And the year passed by. I didn't go to Livingston. I ended up going to this other public facility, which is a clinic close by. It's around Zwide, where I stay in Port Elizabeth. I went there, and then when I got there, I went through the same process, but I wasn't in such of I wasn't disrespected there, I'd say, because they just filled in the file, I guess, because they were going on with my ID, so that wasn't much of a problem. And then I started I wanted to see the doctor, the nurse. I went in. So the nurse, I told the nurse everything as to that I want to access hormones, and I'm on this journey. And she told me that they don't provide such help in public facilities. This is not where I can get help. And even if they did, what sort of help they described to me? So I heard from a friend before that she was using contraceptive pills. So I asked her if I could get those, because that's what most trans women use these days, because we feel like there's so much lack of information as to where we can get pills or medication, hormones in general, and all put together. So when I asked her that, can she give me the hormone pills? She was like, the contraceptives. She was like, contraceptives azinikezelwa olantuka obhuti. Ngezo abantu abangomama. I was like, ewe sisi, nguye umuntu ongumama. Engangabi ngathi kuwe emehlweni wakho, but from me and from how I see myself, I identify as a female, and I am proud of that. I do not care whether you disagree with me. That is your perception. That is your mind. I can't.
eyojonga ufumana uncedo ngee-services zabantu transgenders ne. Andikho sure uba transgender ne. Oh, so i-transgender woman ngumuntu ozibona eziva ezazi uba ungumuntu ongumama ne either segqibelele wangumntu ongumama watshintsha ubunini bakhe okanye akakatshintshi but ngokoziva wena ngokozibona nangokwezenzo zakho everything ethetha ngawe uzibona ungumntu ongumama then you are called a trans woman. Kusihle ke lowo. So usihle uyile ekliniki eyofuna ii-services as umntu ongumama but xa efika phayana kufika khona amakhadi amabini mos ekliniki la ablue nala apink ne. So umuntu ebemnceda uthatha ikhadi eliblue ngokuba emjonge ngamehlo. Then usihle uyamlungisa uba mna ndingumuntu ongumama kutheni le nto uthatha ikhadi eliblue ukundinceda. Uthi no mna ndibona umuntu ongutata. Kulapho baxambulisene khona balwa khona into yobana mna ndingumuntu ongumama and awuzukwazi ukundixelela uba ndingumuntu ongutata ngokokubona kwakho. Ndiyakuxelela mna and nepasi lam lithi ndingumuntu ongumama. So akalufumananga uncedo apho and uthethile nabantu bakhona kwakhona ingxwabangxwaba ke malunga nobunini bakhe. Apho ahambe wofika khona ereferwa esibhedlele nasesibhedlele wafika wafumana the same treatment yobana ujongwa as umuntu ongutata whereas yena engumuntu ongumama ne. Then ngokuthetha kwakhe uthi ikhona ikliniki eyiVits phayana eBhayi Port Elizabeth athe wafumana kuyo uncedo aziwayo khona nabantu bakhona bayaziyo i-information yabantu abazi-trans nabantu nje nezinye iintlobo zobulili ne. So loo klinikhi leyo iyamnceda and if ukhona umuntu okhoyo apha odinga ezo services uthi yena xa efika ekliniki afumaniseke uba ufumana qho ukulwa ekliniki ngobunini bakhe angakwazi ukufumana uncedo eVets naxa ngaba ekwelaa cala laseBhayi ke. But iikliniki ezininzi yena ngokokuqaphela kwakhe into yobana azifundisekanga ngabantu betrans and azinayo i-information ngabantu betrans. Ngoko ke abaphatheki kakuhle abantu abazi-trans kwezi clinics zethu.
Mna ndingusiyasanga ndisuka eButterworth. So
I am Sasanga, I come from Butterworth.
into eyenzekayo kum bendiyi-drug user enzima for more than 10 years whereby bendisebenzisa ii-drugs ekuthiwa zii-men drugs.
So for more than 10 years, I was a person who was using drugs.
So ndadicide uba mandikhe ndiyeke because I think besendimdala for uba ndibe ndisajayiva nee-drugs nabantwana.
So looking at my age, I decided to stop using drugs.
So ndacinga uba since ndingakwazi uziyekela okanye ndithi ndandizibona ndingakwazi uziyekela ndaqonda uba mandikhe ndiye ekliniki eNozuko Clinic khe ndiyofumana uncedo phaya, maybe support groups or maybe izinto endizokwazi uba ndiziyeke ngazo because xa ndizama uziyeka for about 2 or 3 days kwakuba khona i-withdrawal symptoms endingakwaziyo uzihandlisha ngokwam.
So because I saw it difficult to stop using drugs on my own, I then went to consult at the clinic looking to see if I cannot find any kind of support from the clinic. So I went to Butterworth Clinic.
Ekufikeni kwam phaya ndiye ndafika nda-athendwa ke phaya ke so ndiye ndamcacisela kunesi wayephaya ehleli yedwa ukuba ndize ngesizathu esithile, of which yena wathi xa endiphendulayo wathi yena akekho trained enough for ukuba angakwazi undinceda kule nto, so uzondibizela umntu amaziyo uba yena noko ngathi
Her response, she said she's not well informed or well equipped about the information on people who use drugs. Therefore, she's gonna refer me to someone who has better knowledge on people who use drugs. Then when she came back with about 4 other people other than herself.
so kulapho ke waqalisa khona ke ngoku i-questioning because khange bandinike ncedo, instead uba baye bandibuza imibuzo ukuba uziqalela ntoni i-drugs, uzisebenzisela ntoni, kutheni ufuna uziyeka, ziphatha njani, xa kuthiwa uyekile awucingi uba umzekelo ungaphinda urelapse, zayi-interrogation instead of uba uncedo.
So when the 4 other people reached the consulting room, they started questioning me, asking me why I started using drugs and using drugs. And to me, it sounded like more of an interrogation done offering of services.
So bandibuza ekugqibeleni uba njengoba ndisithi ndine withdrawal symptoms ezinzima uba zintoni na ezo, so ndabaxelela uba andikwazi ulala, ndiphathwa yintloko, kungcangcazela and things like that.
So as I was explaining the reason why I wanted to quit using drugs, explaining and telling them about some of the things that I was citing, like not being able to sleep or sweating a lot while I sleep, I was explaining this to them.
So interrogator to a point of ekugqibeleni khange bakwazi undinceda. Bathi abanazo ne-support groups, abanabo abantu trained enough for uba bangandinceda kwinto ezinjalo, abanayo i-medication appropriate for ezo zinto. Bandinika i-Elegex for ukulala, bandinika i-paracetamol for intloko, and then bandigoduse emveni koko.
So during that consultation, I was only questioned, and the response, I would say a positive response I got from them, is that they do not offer any services for people who use drugs, and they do not have any supportive groups for people who use drugs. But for the reason that I'm not able to sleep, they only gave me Allergex and a paracetamol. Then I went home.
So ndathi ndazinceda ngokwami ekugqibeleni because ndabona uba ukuya kwi-health facility ayincedi ndawo, to a point okuba ndikaphinde ndiye kuloo klinikhi okwangoku.
So I ended up helping myself and making sure that I quit drugs on my own, and not needing any services from the facilities. From today, he's clean, he's not using drugs. Congratulations, Pusia.
Thank you.
So sorry, Jess. Oh, better uvela the face.
Molweni. Esam story ndizothetha nge-attitude eyenzeka e-clinic, yenzeka kum phofu e-clinic, but I feel like yenzeka nakwezinye clinics. Ngokokuva kwam kwicala le-LGBTIQ.
So I'm only going to talk about the attitude that I received from the facility that I use, because I feel it happens to most of us as people for LGBTIQ. It's only on the staff attitude I received from the facility that I use.
I went to Stanford last month. Ndine problem, had an infection. So azot ndingene apha consulting room ndiye komnye unesi. Xa ndisithi ezanceda unesi avele ahleke. Uhleka kwakhe ke ndaye ndambuza uba uhleka ntoni, wathi le mikhuba uyenzayo awuzothi ungabi nayo i-infection.
So I went to Stanford Terrace in Alberta. I had an infection. So when I got to meet the nurse at the consulting room, she laughed at me when I explained why I was there. And she further told me that there's no way I wouldn't get any infection due to, I'm not showing me kuba by doing this long, but due to me sorry.
So aphume abengathi uzanceda ahambe ubiza omnye unesi kanti bafuna ubonisana ngam. Of which I understand into yobana ngaba isizwe siyaphela and kukho abantu abahleka abantu kodwa ba-trained uba mabenze umsebenzi wabo.
So from the way she conducted herself, I thought she was going to help me, but she went out to get other nurses so that they can laugh at me. And I believe that was wrong, because the world is like this today because of people like that. And nurses are supposed to be people that are helping others, but they are not doing their job.
So ndaye ndayoyiripota ke lo problem leyo because ndaye ndaphuma andasanida ngoncedo. Ndahamba ndayoyiripota kumphathi wabo, but umphathi wabo I think befuna uprotecta istaff sakhe. Zange laa nto ayithathe serious into endandiyithetha. Even the suggestion boxes bakhona ekliniki but ziyakhutshwa la maphepha lawo. I was once in the clinic nam. So izizinto ezenzekayo ezo ezifuna ukupheliswa.
So from the bad service that I got from the nurses in that consulting rooms, I went to report them to the facility manager, but the facility manager showed no care towards me. And I even told her that we do have suggestion boxes, but you do not open and do not pay heed to those suggestion boxes. So I see that the attitude there at Stanford is not conducive for people like us.
And not only is Stanford, ukubona kwami kusenzeka lento, see group of LGBTIQ society, more special gay guys, in our Tambo, we are dying. And in Jembe Sisifa, uncedo boyoyika because umuntu akakwazi ukuya eklinikhi uyoyika uba kukhona unesi, but I'm not going to mention names, uza kuthetha because he's friends with gay guys zaphayana, athethe ahambe ethetha ngezinto zakho, I mean ngezigulo zabantu abafika phayana. Take for instance, gay guys ezininzi azifuna ukuya phayana. And I feel like people are defaulting because of bayoyika ukubheka ngaphambili bayofuna uncedo. Kuhlekwa ubugay bakho, kuphinde kuhlekwe nesigulo sakho esunaso, sigcwale i-OR Tambo yonke.
Not specifically citing out Stanford terrorists, but the whole of Wartambo. As the LGBTQI community, we feel that we are not paid attention to, and we are afraid because most of us are dying and we end up defaulting from our treatment because of the poor service that we receive in our facilities.
Okay, so no, I think I'm done now. But eyona nto bendizoyicela ingaske I don't know uba ingenzeka kanjani, but amanesi ingaske atrainelwe ilantuka, atrainelwe ukuba how to deliver i-services to ilantuka i-gay community, because i-gay community bona kuqala bengamanesi bayakwazi ukuthetha ubana ngaba uzawufumana isifo esithile uzothi umuntu angathethi nawe kakuhle as a professional. So loo nto leyo yile yenza uba makunyuke i-high rate ye-HIV in the whole South Africa, because kuhlekiswa ngayo yonke loo nto leyo.
Thank you, comrades. Before we go to recommendations, I think it's important that I inform the House and also thank Mr. Somayela for acting very fast. Usisi Lobehleli pha, she went to NU1 clinic to collect a treatment yakhe through the arrangement ka Mr. Somayela. Masimpheni izandla comrades Somayela. With the hope, Mr. Somayela, ukuthi usisi will not again miss a treatment yakhe because of a piece of paper. Piece of paper is not important than a life yakhe. Transfer letter or no transfer letter, she must be assisted. Comrades, before I go to the recommendation, man makaban. One of the problems, Ngokil, is Bangela that makes honest to continue abuse us is because we are scared to name and shame them. When we call these nurses who are doing all these injustices to us, when we name them, mention their names, it's only then that things will be resolved. We can't leave it like that. TAC members in OR Tambo, PLHIV sector leaders in OR Tambo, we need to work with the LGBTQI community. If it means we must start the petition of shaming that nurse and all the evils that nurse is doing to the LGBTQI community, take that memorandum straight to the MEC, let it be like that. Anywhere where the LGBTQI community's rights are violated, let's organize ourselves, let's organize communities, let's name and shame those nurses, let's make petitions to clinics and submit them to the facility managers, send them to Aneleao. Aneleao will send them to the Minister of Health and the MEC of Health so that something is being done with immediate effect. We have been talking too much, comrades. People are dying. Now it's time for us to act and stand up for our own rights, because if we do not stand up for our own rights, nobody is going to fight for us. And if we do not fight for us, we will die. After Siswelegile, we can't speak anymore and we won't be able to fight for ourselves. Here are the recommendations, comrades. Any reports of poor staff attitude, privacy violations, verbal or physical abuse or harassment and or off service being restricted or refused should be urgently investigated. by DOH and PEPFAR and disciplinary actions taken where appropriate. Facility managers should be held responsible for unresolved issues. For facilities we report on here, the Department of Health and PEPFAR should respond within 3 months with actions that have been taken. Department of Health and PEPFAR should ensure that all clinical and non-clinical staff, including security guards, across public health facilities are actually sensitized on provisions of KP-friendly services to ensure a welcoming and safe environment for all key populations at all times. Key populations must be involved in the implementation of these training modules. Post-sensitization training. The Department of Health and PEPFAR should complete follow-up to assess the quality of KP services provision at site level to show the success of the sensitization program. National Department of Health and PEPFAR should designate at least 2 public health facilities per population per district to serve as key population designated service delivery centers. 1 per province for all key populations will not be enough. Site selection should take into account local context, and facilities may serve more than 1 population, but may not always be appropriate to combine all key populations into a single settings, given differential needs between key population groups. These sites must be allocated additional staff and resources to provide comprehensive health services to the specific key population being served. The Eastern Cape Department of Health, match, and TB HIV care should ensure that barrier contraception, including condom, compatible lubricants, male and female condoms, are easily available at public health facilities, not only upon request or in public spaces that make it difficult to pick them up. The Eastern Cape Department of Health, match, and TB HIV care should ensure that all key populations are offered PrEP at public health facilities. Department of Health and PEPFAR should ensure that harm reduction services, including drug dependence treatments such as methadone, are made available at public health facilities. Department of Health and PEPFAR should ensure that trans people are able to access hormone therapy and gender-affirming services closer to home. Where people who use drugs and or trans people need specialized care from drop-in centers or public health facility offering specialized care, they should be provided with easy referral and adequate resources, including transport, money for transport, to uptake those services. Over to you, Ndi.
Thank you, Chairs. Now, the following set of issues specifically speak to the accessibility of services in government-run clinics by men. The proportion of men who knows their HIV status and accessing ARVs is much lower in South Africa. While men only account for 1/3 of new infections, they account for more than half of the HIV-related deaths, pointing to a major challenge in men's uptake of HIV treatment services. About 30% of HIV transmission occurs among stable partners, and HIV-positive partners among serodiscordant couple is more commonly male than female. This, together with growing evidence that antiretrovirals reduce HIV mortality and morbidity more. So if treatment is started early, and potential benefits of viral load suppression in reducing transmission make men a critical target population to reduce HIV incidence or mortality. Positively, Ritshidze data shows that 25 facilities have men's corners. However, 8 facilities reported having male nurses, counselors, or healthcare workers at the facility, which bring us down from 27 facilities in the same reporting period last year. Furthermore, only 4 facilities reported having male outreach services, and only 1 facility has male clinic days to encourage men to uptake services. MESH and TB care should ensure that there is at least 1 male nurse or counselor at each PEPFAR supported site, and that interventions like men's corners are implemented to support male uptake of services.
Thank you. So here are the recommendations, comrades. By April 2023, match and TB HIV care should ensure all PEPFAR supported sites have at least 1 male nurse and 1 male counselor in place, leading to a greater uptake of services by men. And 2, by April 2023, match and TB HIV care should ensure all PEPFAR supported sites have at least 1 male clinic day per week or men's corner, ensuring male staff are on duty and integrated into service delivery to provide services specific to the needs of men. Thank you.
Thanks. Now we're going to touch on issues around index testing. 98% of facilities monitored through Ritshidze report engaging in index testing. While index testing has the ability to help identify individuals who may have been exposed to HIV earlier, it must not be implemented in ways that cause harm to individuals and undermine their rights to consent, privacy, safety, and confidentiality. Data from Ritshidze shows that 1,268 people living with HIV interviewed. Of them, 73% said that a healthcare worker had ever asked them for the names and contact information of their partners so that they may be able to test them for HIV respectively. Worryingly, of the 928 who were asked to disclose their contacts, only 75% reported that the healthcare worker explained that they were allowed to say no or refuse to give the names of their partners. In the table here, it shows that 14 facilities had perfect scores, with 100% of people living with HIV reporting that they were told that they could refuse, which speaks to the correct consenting that was done during the process. However, at 15 facilities, less than 70% of people living with HIV reported being told they could refuse, with some sites such as Pilani NU1 Clinic, Flagstaff Clinic, Duncan Village CHC, Kaugeni Clinic scoring particularly low. While not the worst, the Eastern Cape did score below the national average on this indicator, and improvements need to be made to ensure that index testing is always voluntary. We are also concerned that screening protocols are not always being followed. Positively, 94% of facilities screen people for intimate partner violence as part of the index testing protocol, up from 83% in the same reporting period last year. However, 52% who do screen for IPV still contact all partners regardless of reported violence. Further, only 75% of people living with HIV reported that they were asked about the risk of violence from their partners, a slight increase compared to 71% last year. This is a concern and major violation of people's safety and privacy. There is no point to the IPV screen if contacts are just notified of their exposure anyway. Zero contacts who have a risk of violence should be contacted. This is extremely important in the context of South Africa, a country with a well-documented epidemic of gender-based violence. Positively, 10 facilities had a perfect score, with all people living with HIV reported being asked about the risk of violence. So in Buffalo City, this was Zanempilo Clinic. In Amatole, Nozugo Clinic is amongst some of those facilities. However, at 14 facilities, less than 60% of people living with HIV reported being screened for IPV, with some sites such as Letitia BAM CHC, Palmerton Clinic, Luyolo NU9 Clinic, Maluti CHC, Mount Frere Gateway Clinic, Fezega NU3 Clinic, Grey Gateway Clinic, Kaugeni Clinic scoring particularly low, as well as on following screening protocols. The Eastern Cape, once again, Department of Health, match and TB HIV care must act urgently to ensure that all sites across all districts follow the protocols outlined in the Department of Health guidelines on index testing. Index testing must be suspended in poorly performing sites until it can be carried out safely and with consent. There should be an investigation into all sites carrying out index testing urgently to understand if this is a broader challenge in the province or not. The findings of this investigation should be shared transparently. Those who are failing to uphold the safe and ethical index testing standards should be held accountable and action should be taken. In terms of Ipv services, positively, 87% of sites said that if people living with HIV screen positive for intimate partner violence, they offer them services either on site, while 51% of sites said that they offer a referral. The Eastern Cape is performing second best on this indicator, yet all facilities should be able to provide on-site or referral services for intimate partner violence. Screening for intimate partner violence without adequate intimate partner violence services to respond to an individual's positive screen is both dangerous and unethical. Referrals must be actively tracked to ensure individuals access them, and referral sites have adequate capacity to provide services to the individual. Now going to move on to the recommendations.
Thank you, Comrade Ndi. Tatu Somayela invisa kabuhlungu into yoba kuthiwe iLetitia BAM CHC is one of the underperforming competence call. Yi-clinic yam le. Phakanobuhle, yi-clinic yam le. Invisa kabuhlungu ngoba uNoloyiso, the PM of TAC, she is looking at me with la mehlo athethayo ukuthi ungxola kakhulu apho soka khona kubi. I'm worried. Thank you. So the recommendations are as follows. In order for index testing to start or restart at sites, the Eastern Cape Department of Health match and TB HIV care must ensure the following. 1, index testing is always voluntary, and that people living with HIV truly understands this. No index testing will occur without the informed consent of a person living with HIV. 2, people living with HIV are screened to see if the individual's partner have ever been violent, and the answer to this is recorded. No contacts who have ever been violent or are at risk of being violent should ever be contacted. 3, adequate intimate partner violence services are available at the facility or on referral or indexed testing should not take place. And number 4, all adverse events are monitored through a proactive adverse event monitoring system with follow-up to assess violence, disclosure of HIV status, dissolution of the relationship, loss of housing, or loss of financial support. The Eastern Cape Department of Health match TB and HIV care must suspend index testing at any facility that cannot meet these demands. Over to you.
Thank you, Shares. Now the next set of issues are on TB infection control. TB remains the leading cause of death for people living with HIV in South Africa. One key area we monitor around TB is the level of TB infection control at our clinics. We asked 7 questions to assess TB infection control at clinics as outlined on the graphic on the left. The 7 measures are ensuring enough rooms and space for public healthcare users to wait without overcrowding. Keeping windows open, ensuring there are TB information posters prominently displayed. During facility waiting times, reducing facility waiting times to less than an average of 1 hour, 15 minutes. Screening all arriving public healthcare users for TB symptoms. People who are coughing, who have TB symptoms, to be given masks to wear on arrival, and separate people who are coughing on arrival at the facility. No facilities were awarded green status for checking all 6 best practices measures on the scorecard. Ritshidze scored 21 clinics yellow status. This translates to about 44% of the being monitored, following about half of the best practice measures for infection control. It leaves 27 facilities or 56% of clinics surveyed failing altogether at meeting these 6 basic best practices to stop the spread of TB. Overall, much more still needs to be done to ensure that all clinics are at the required level of for TB infection control. For years, we have been calling unsuccessfully for certain measures to be adapted, only to see key measures made quickly possible during the COVID-19 pandemic. If we are able to educate people about COVID-19 infection control, to ensure the use of masks in clinics, to screen people for COVID-19 symptoms on arrival, to ensure the provision of COVID-19 posters in all African languages. These are things, then these things are also possible for TB.
Can we get the community stories? All of those who've got a number 9.
Molweni. Sisuka eMatatiyele. Ikliniki yasemagadla ndaba neproblem ngumntana wesister yam uthatha treatment.
I come from Mdantsane, from a clinic called Magadla Clinic.
Kunomntana ke efemini ngatana ke ezimana ngabasoleza treatment. So bemane thathelwa ngumgogo kwe-treatment bamsokolise bangangayifumani.
There's a child in my family that takes treatment, and her grandmother usually collects the treatment for her.
Emane siya ke ugogo abuye emane ndifowunela ndihlala ke naye mna ndihlala elokishini area C. Ubani okuzola sifumane treatment yomntana gogogo newaseside sine 2 months mane ndiphinda pha.
So my grandmother, while going there, she sometimes do not get the treatment for the child. So she ended up calling me for me to go collect the treatment for the child at the clinic.
Unfortunately ke nam busy ngumsebenzi ndafowunela umalume wandicela azame ukuya ayova uba uqhubeka ntoni uba umntana angatholi treatment.
So as I'm busy at work, I couldn't make it to the facility. So I called my brother so he can go and hear what is going on at the clinic.
Waya ke umalume uye wahlala from ekuseni ukuthi wafika ngo-7 kwabetha o-3 bangamncedi. Wayenda baseke give up ke waphinde ekhaya back wandixelela ke akayifumananga i-treatment yomntana still.
So when my brother got there in the morning, he waited and waited and ended up coming back, not receiving the treatment.
So ndadecide uba kungcono ndiqabele ndiye eMagadla ndiyocela i-transfer letter for umntana ndimthathele elokishini eMatatiyele ekliniki.
So I decided to go to the clinic myself and request a transfer letter so that I can collect the treatment for the child to the clinic closer to me.
Wandenzela ke usise nafikela kuye ndaya eMatatiyele ekliniki bangandisokolisi early this year bangandisokolisi bandinikeza i-treatment yomntana.
So earlier this year, I got the transfer to Matatia Clinic and I got the best service there. I didn't have any experience.
Lately, apha June, July, kwi-date yomntana bayothatha treatment, ndaziyela ngokwam ngelunch, ngabo-1.
So around June, July, on my lunch break, I went there myself to collect the treatment.
Ndiye ndahlala ndalinda phaa kwacaba ndafike ndajoyina ityhu. Ndalinda caba ixesha liyandiphelela ndayocela kusisi kwi-reception uba sisi bendicela uba nindilungisele msi i-treatment yomntana because ndiphinda emsebenzini.
So because I took my lunch break and decided to go collect the treatment, I had to wait there. So I then requested the sister there to come and help me because I am on lunch break.
Wathi ke usisi xa ndiphendula akukho umntu ungafumani i-special treatment apha, mandiphinde kwityhu.
So she answered saying, I will not receive any special treatment. I should go back to the queue.
Ndaphinda nyhani kwityhu kuye kwabetha u-3, ngabo-3 ndaqonda uba kuleythi ngoku ngeke ndikwazi ndaphinda ndahamba ndagoduka ndaphinde emsebenzini ndagoduka ndingayicolanga i-treatment yomntana.
At around 3, I saw it was too late for me to go back to work. I then decided to go back home without the treatment.
The following day ndacela omnye usisi ke udla ngokuthunywa ke phaya apho sibenzela khona umnike imali xa umthumile. Bandicela ndiyele eklinikhi ndithathe i-treatment yomntana wavuma nyhani.
So the following day, I had to ask someone in the community who does the collection and gets paid for the collection of treatment for the people around that community, and she went there for my collection.
Uhambile ke uye ekuseni ngabo-7 kwabetha o-3 akabuyi ndapenika ke ngokubuza inoba uhlalile ntoni akanafowuni ndalinda kodwa uba makade abuye ndive ingxaki uba yintoni.
So as she went there in the morning, now it was around 3, and I was starting to panic because she was not coming back either.
Wabuya ngabo-3:30 xa kebuya still akayiphathanga treatment yomntana ndambuza hayi bo sisi treatment iphi wathi bamthe kuye abazukwazi ukumnika because idate yayo yakhe suppose uba idate yomntana izolo. Waba-explainela uba uncimakazi womntana bekezile. But wabuya esithi akakwazanga kuncedakala ngenxa yekuthi uthi akazunika i-special treatment. Bangamnika still wabuya ke enjalo ngenxa yoba kuthiwa uze ngedate engasoyiyo.
So she came back empty-handed, saying that they told her that the person for whom she was collecting the treatment had missed their date, and they cannot give her the treatment on a missed date.
Ndafowunela umakhulu ke ndamxelela sonke istori because yena besekebukhala uba i-treatment yomntana ayizi na because ayiphelile.
So I had to report back home that I could not get the treatment either, and by this time the treatment was no longer available at home.
Umakhulu ke waziyela ngokunokwakhe the following day wabaxelela uba xa bengamniki i-treatment yomntana ngoba kuthi bebemsokolisa uzawuba yobaripota kwi-social workers. That's where ke wayifumana khona i-treatment.
So my grandmother then decided to go there by herself, and she then threatened them that if they don't give her the medication, she will then have to report them to the social workers. So it's only then that they were able to give her the treatment.
After that ke akhange siphinde sibe nangxaki ngaphandle kuleyo ke.
So after the threat from my grandmother, we never had any problems. Thank you.
Moving on to recommendations.
Thank you. Thank you. So the recommendations are as follows, comrades. By end October 2022, the Eastern Cape Department of Health should send a circular to all facilities to ensure that all windows to be kept open, TB infection control posters to be displayed in visible places in the waiting area, public healthcare users to be screened for TB symptoms upon arrival or integrate with COVID-19 screening, people coughing or with TB symptoms to be seen first to reduce the risk of transmission, people coughing or with TB symptoms to be provided with masks, People who are coughing to be separated from those who are not while waiting. By end February 2023, the Eastern Cape Department of Health should carry out a full audit of all public health facilities in the province to assess whether sufficient TB infection control measures are in place. Thank you.
Thank you, GS. We are now going to go into issues of stockouts and shortages of medicines. Stockouts and shortages of medicines, vaccines, contraceptives, and tests cause disruption, confusion, cost, and can cause treatment interruptions. At times, healthcare users can even disengage from care, seeing no point in going to the clinic to be sent home empty-handed. In this reporting period, 7% of people we spoke to had left or knew someone who left a facility without the medication that they needed. The Eastern Cape performed the best on this indicator with the fewest reports of stockouts by public healthcare users nationally. This graph shows public healthcare user reports of leaving the facility without the medicines that they needed over time. If you look at the graph, lower scores are better, so you can see that the province has had many ups and downs across the reporting periods. Facilities also reported stockouts, as shown in the graph in the slide. Facility managers' most common stockout category were medicines or diagnostic tests at 13 sites, pregnancy tests at 10 sites, HIV medicines at 9 sites, and vaccines at 5 sites. We also look at the public healthcare user perspective on reported stockouts. Public healthcare users most commonly reported stockout category were contraceptives, pregnancy tests, as well as vaccines. Of the clinics that experienced a stockout or a shortage as reported by the facility manager, 15% were forced to send people away empty-handed, while 44% provided an alternative medicine and 8% gave a short supply. We need to ensure that people living with HIV and other public healthcare users are able to get treatments that they need when they do go to the clinics. We're going to go into some of the recorded stories.
Ndiya ekliniki evillage ndithatha khona i-treatment yam umthetho wakhona ndingumntu we-treatment phaya. Ngoku sifika phaya sihlale, kodwa ke thina sibadala sithathwe singeniswe ngaphakathi. Sifike ke ngoku phaa ngaphakathi sihlale basisebenze, banegame yokuba bemke bahambe bobuya ke ngoku sebebhomba, besesibhombisa. Mama, kwathini ungathangani? Ubuxolisa. Hayi, ndiyaxolisa abantu abam. Mna andikwazi kakuhle ukuhamba ngeenyawo ngoba andiboni ngamehlo. Ndive ngathi ngone ndihamba ngathi ndizawuwa. Ndabona uba mandigayi ngokwekliniki, ndaphetha ndiyekile. Ngezinye imini siyazifumana iipilisi, ngezinye imini ubone unikwa, nosowufikwa apha ekhaya uvula laa phepha basifakele kuso. Aziphelelanga iipilisi zethu esizityayo. Ikliniki yintoni, imobile? So ke ngoku ke iba nexesha lokhe ingafiki. Ngelo xesha engafika ngalo ndiphelelwe yi-treatment. Kulaa nto uphelelwa kwam yi-treatment, uyaqonda? Kulaa COVID zange sibe nayo ikliniki apha, ibisibaleka. Yeyona nto singayixelelwayo ukuba kutheni na. Jonga singaphi, ngoLwesine kule veki ipheleyo. Eke yithi ke ndihamba nzima mna, andikwazi uhamba ngedolophu. Nako ndinyuka ekuseni bawutsho phaya fike phaa kugcwele ngabantu. Yeyi wabetha u-10 wabetha u-11 wabetha u-12 kwala nxa zileqa i-12:30 kwafumaniseka into yoba abantu bayancama i-bicarbonate of soda. Bendisithi nxa ndingenayo ipilisi ndithengelwe yona, ndithathe amanzi ndiyizamisele emanzini, ndithathe iviniga emhlophe ndigalele ibile ndiyisele kuthi rho. NgoLwesihlanu ayafika tu ngoLwesine wafowuna usisi lo efowunela uba kutheni na abantu behleli ngohlobo ugcwele apha ngabantu. Babe besithi bona umphendula kwakhe, hayi asimboni udrayiva, yona imoto ikhona apha esibhedlele.
Ndihlala eNew Life. ENew Life ikliniki izanzima. Ndineminyaka ndineminyaka emihlanu ndilapha. Ikliniki iyafika. Xa ingakanga ifike, ayifiki inyanga iphele iyosongena kweyesibini. Sayifumana phakathi kwinyanga yesibini. Xa bafikileyo bamayeza awakho, bathi ayawakho. Ngeli xesha nxa bafuna uhamba noba likabethi ixesha loba mababhale bahambe, bayabhala, bayahamba. Bashiya abantu bedwelile befuna ikliniki. Ke ngoku mna andisakwazi uqala lo nyaka upheleyo, andisakwazi uhamba ukuya ngokwam ekliniki. Ndithathelwa ngumntana iipilisi. Akwafufuzi ndihleli ndawonye, andiyazi noba ndigula kangakanani na, noba ukufa kuhambela phambili, noba kubuya umva, andiyazi. Ngelinye ixesha siyahlala, bayahlala abantu phaa balinde ikliniki ingafiki, ingafiki nakuveki ezayo. Laa deyithi ubuxelelwe ngayo igqithe yona ungayifumani. Kule ndawo ndihlala kuyo bebekhona ezantsi abantu ahambe bejikisa besipilisi nabantu abakhangela uba nigula kangakanani na, nabantu awujonga amaxhewukazi bawavasele bawaphekele. Apha ayikho loo nto, akho nabantu abajikelezayo.
Mhlali walapha eNew Rest, ndiklinika eMqanduli. So bendike ndanatsika ndazifumana iipilisi ndayozifumana eMthatha eGateway ngenxa yoba besingekho apha eMthatha Gateway. So bendisafarisha nalapho kuloo meko leyo uba kaloku bekunzima uba ndiyozithatha. Bendithatha itritimenti ye-HIV, ye-ARVs, i-regimen 2 besengekho apha eMqanduli. So ke ngoku bebesithi bengakwaziyo uba bastokhe uba kaloku asikho, nakho bantu batyayo apha ngaphandle kwam. So ke ngoku ke sibabini ke qha abantu abatyayo esapilisi. And ke ngoku andibinayo laa 120 yobana ndisiya phayana yonke inathi qho ngenyanga oko ndiba ndisiya, because ndixhomekeke kwimali yabantwana, 40 grand.
That are associated with stock outs. So from October 2022, there must be effective and immediate communication of stockouts between the National Department of Health and Eastern Cape Department of Health, and to healthcare workers and public healthcare users as well. By January 2023, the Eastern Cape Department of Health should establish an emergency response team and standard operating procedures to manage crisis situations. We call on them to include clinic committee members, all PLHIV sector organizations, and the Stop Stockouts project. By January 2023, the Eastern Cape Department of Health should ensure all pharmacists have been trained in CVS and other supply chain systems. From April 2023, the Eastern Cape Department of Health should implement a provincial strategy to address stockouts and shortages of medicines and other medical tools and supplies. This must address the impact of human resource shortages, poor management and infrastructure, where these impact on the ability of facilities to order and store supplies. Increasing the number of pharmacy staff in facilities must be a priority, as they are often the first to acknowledge a short supply of medication. By April 2023, the Eastern Cape Department of Health should employ an additional 10% of pharmacists or assistant pharmacists. Pharmacist shortages were reported at 24% of sites monitored, and assistant pharmacists at 28% of sites that were monitored. We now move to closing.
Thank you, Comrade Devu. So now, siyanga semaphethelweni zinkokheli. Before sinike Department of Health to respond and commit and other partners that we are working with, I think it's important ukuthi dinikeze kwinkokheli ze-HIV sector. Noba inkokheli nganye imizuzu emibini. Unfortunately, Comrade Utoko from the Eastern Cape Health Crisis Coalition, she had to go because she's got another meeting. Without wasting time, ngizawubiza uComrade uNontsikelelo Gcwabe from NAPO athi qaba. Kuyo yonke le report sithini thina as people living with HIV in Eastern Cape. Senza njani ukusebenzisana ne-department ukuthi ezi problems zibe kanti ziya-addresseka ngokuthi singene down kwi-communities, work with the department and ensure ukuthi people living with HIV key populations and the public healthcare users don't experience these problems. Over to you, Comrade Ntsikelelo. And then after Comrade Ntsikelelo, izaba ngumfundisi wami.
Molweni comrades. Nandicinga ukuthi kwi-Department of Health, if shortage of staff akayihoyi, isinikeza ingxaki because kusetyenziswa security guard abanye ngomsebenzi wawo umsebenzi wekliniki. Security guard kuzawuthiwa kuye makahambe ayothatha 5 incwadi zabahlali zongena ekliniki abazothatha treatment. Kuthiwe makazothatha 5 zabaguli azingenise ngaphakathi. Apha endleleni esuka ebahlalini ukuya ngaphakathi, we don't know uba kwenzeka ntoni na. Loo nto ilenda ekubeni i-confidentiality inga-maintain. Into eza kulandela u-security guard lo ebenikwe eza ncwadi zabantu akatreyinwanga kwinto ye-confidentiality. Sizawuyiva elalini ukuba ubani nobani udla amapilisi. Okwesibini, ndicela kujongwe into ye-welcome back campaign. Ihleli ezincwadini ukuba mayenziwe njani na. Bawufika abantu ezikliniki akuthethwa laa nto ibhalwe encwadini. Abantu bayajikwa. Mind you, usuka ekliniki, usuka endlini, ubudifoltile, uzincame uye ekliniki. Xa ufika ekliniki kuthiwa iya emva etyhwini ubuvukile, uphinde ubuye ekliniki. Meaning that ke ngoku sidlaliswa umdlalo wamasele. Sizawubuyela emva qho. Kodwa ke apha zabo ze-AIDS Council basifuna u-95%. Andiyaba samfumana phi na abantu begxothwa ngabo. Ndicinga uba kunolungiswa ezo zinto yi-department, singana indlela esibheka phambili. Andiyazi ke noba kufuneka sidilize ke ngoku ezi round table na sibuyele kundalashe na ukuze izinto zilunge. Asithandi njalo because sicinga uba sifanele uba siyasebenzisana. I-Department of Health ayisenzeli ifavor ne. Iyasinida, siyayinida. So uba singasebenzisana kungakuhle, kungangabikho ezi zikhalo. Azimandanga ezi zikhalo. Ngabantu bethu abaya. Sitsale nzima ukude sifike kule ndawo sifike kuyo. For into yokubana ngoku into esesiyifumene isezandleni zethu iphinde ngoku ihluthwe ngabantu abangayaziyo noba sasiyifumene njani. please ndiyacela ukuthi i-department before side sidinwe ekhe sadinwa abazokwazi ukuphelisa udina kwethu. Kuyawuba kubi. Enkosi.
Enkosi mhlali ngaphambili. Sihlalo ndicinga into yoba kwixesha elizayo khawusincede ngezi partners sisebenzisana nazo. Ngoba ndicinga uba enye yento ebithethwa apha yemoto, uba ndiphazama imoto ka-TB-HIV care evele nje ihambise itreatment yabantu ingamxelelanga umntu uba ndiyeza. Kulungile ke, mhlawumbi ke mhlawumbi ngaphambili masivumelane into yoba istatement sika former president uThabo Mbeki kukho abantu abasincedisayo kwi-department. Basincedisa ngolu hlobo lento yoba endaweni yonceda abantu bayabagxotha. Eyona nto endirhalela into yokokuba mna i-department isincedise kuyo Mr. X ngulo mcimbi uba wonke umntu ukhala ngawo into yoba uba uphoswe lisuku lakho lokuthatha itreatment kuthiwa buyele emva. Umzekelo ke ndidla ngowenza kulaa dolophi iliplasi ndisuka kuyo yaseJamestown, imajority ngabantu abasuka emaplazini and aba bantu abanayo i-public transport. Baxhomekeke kumlungu weplasi mhla ebheka edolophini. Uba itreatment yakho uyithatha nge-15 aba umlungu esithi ndizawuya nge-27 edolophini, akanayo enye nantsika i-alternative ye-transport. Ilishwa ke siqashelwa abantu esele befika bediniwe. Ukufika ediniwe kumntu koku uyele nje laa mini yokurhola agoduka abuyele endlini. Okwesibini, imnandi into yoba qho thina civil society sibizelwe kulaa magumbi sitreyinwe senziwe yonke loo nto. I-department ibatreyina nini abasebenzi bayo kuyo yonke le nto sitreyinwa kuyo? Ilihlazi into yoba uyawuze ufike umntu ongenayo nephepha lento zakwa-health exelela umntu oqeshwe nediploma into yoba bengafuzekanga le nto uyenza olu hlobo, bekufuze uba uyenza olu hlobo. Enye into endirhalela into yokokuba sincedisane ngayo nesebe ngumcimbi weemfihlo zabantu. Bayaqeshwa mana abantu endazi noba apha elwimini labo bavele bathufelwe ngoba babe nolwimi bonke. Kunendawo kunabantwana besikolo abangakwaziyo ukuya ekliniki because unesi osebenza phaya yitshomi kamama. Make yocwangcisa lo mntana unevalo lento yoba kuzawuthi nawe sowusazi amakhwenkwe. Forgetting into yoba abanye abacwangcisi abafuna izikhondom because belala namakhwenkwe but bazikhusela kwezi ndlobongela zifana nathi zidlwengula abantwana. Abanye abathi mabeyocela ii-condoms, andivanga mntu kothetha ngakhondom apha. Kodwa ilishwa into yoba siyayazi uba iikhondom azisekho. Kodwa simile into yoba masikhusele into yokokuba inganweni intsholongwane. Izawunganweni njani iikhondom zingekho? Kule ndawo nisilelise kuyo Ritshidze akukho zikhondom. And andivanga mntu ubuzayo kula macomrade into yoba ziphi ikhondom. Not that zizawusetyenziswa but ukubonakalisa into yokokuba bekufuze uba zikhona kakade kwindawo, especially indawo eziyi-public. Ayi-B&B ayo-private kuba isetyenziswa ngumntu wonke. Mandizawugqiba ke mhlali ngaphambili, ndifuna ucela le nto ithi Mr. X. Kamnandi ke niya kulaa district yam for i-World AIDS Day. Ii-condoms sizigqibele ngo-2019. Inoba uqala undiva ndiyithetha. But emveni koba uncedisile ndafika ekliniki zikhona, ziphinde zaphela. Inoba funeke kude kuthethe umntu we-community uze ziphinde zibe khona, Andiyazi ke noba bantu nibaqeshayo abayazi into yoba makuodwa njani nini. Ekugqibela ke mhlawumbi ngaphambili mandiyithethe into yoba i-department mayisincedise kulo mcimbi woqesha. Le nto bendisithi ingaske ezi partners bezilapha, le sector ya-advocatela into yoba makuqashwa i-HIV ambassador uqinisekisa into yoba kuqashwa abantu abathi mna andinanto uthatha iphiki ndifotwe because ndiphila gabalala nge-HIV yam. But ilisho into yoba kuqashwa umntu kuthiwe uyi-HIV ambassador. Athe sawubuzwa athi andikho comfortable udisclose i-status sam. Abantu i-disability idla ngokuthi there's nothing for us without us. Yile nto ke ninengxaki nento yoba niqashwe oo-data capture abambalwa because yenye ingxaki engathethwayo into yoba bayashota. EMasakane Community Clinic uba uke wabetha u-1 laa chephu ithathe isitsixo semoto wayo ithi ndiye elantshini, nizawulinda uba udicide ungabuyi akabuyi elakho mntu uzambuza. Kubizwe ke abantu i-community mhlawumbi kubizwe i-clinic committee athi makefika athi hayi bendivumelene no-operational manager. Eyona nto endiya kuyo into yoba as much as i-department iqesha, kulaa nto kuthiwa kuthestwa abantu abarongo iqesha abantu abarongo nayo kwiiposition ezingezibafanelanga.
Molweni bethunana.
Umntu ola.
Igama lam ke ndilongile njengoba selichaziwe. Ndiyabulela kakhulu ke ngale mini namhlanje. Ndibulela uRitshidze, ndibulela i-department zonke ezikhona apha. Kuthethiwe bethunana into ezininzi apha. Okumele thina bantu besekta i-leadership into yoba ngoku siqale sisebenze kakhulu. Ayimandanga into yokuba umntu axelelwe into yoba uphila nentsholongwane. Xa ke gqiba apho kuhlekwe. Xa kugqitywa ukuhlekwa aphume engaphathanga treatment. Ibuhlungu kakhulu laa nto. Ibe nangoku uthi andikayithathi i-treatment. Ithini laa nto apha emzimbeni wakhe? Okanye kumeleke into yoba ayithathe umzimba wakhe sewudlakaziwe. Yinto efunekayo leyo? No, asiyifuni ke thina. Okwesibini, Utata Somayele, ndiyabulela ukuba ulapha kakhulu. Ndibulela kakhulu ukuba ulapha. Ndifuna ubuza. Ngicela ubuza apha kuwe, Utata Somayele. Kunekliniki endiphangela kuyo, eNcorha Clinic. Phaa kulaa klinikhi ndifuna uqonda into yoba na kukhona into ebhalwe uvela phansi, Department of Health, into yoba ngolosihlanu kungaphangelwa. Abantu bangancedwa na? Abantu bajikiswe kungazifayeli na? Babe bhizi ngelo xesha. Siye kulaa nto ye-stock out. Sithi amayeza aphelile ezikliniki, amayeza awekho. Bahambe banyuke bonke baye phaa phezulu. Bafike kuyochithwa amayeza la anganikwa abantu. Ayochithwa kuthiwa expirile achithwe. Ngelo xesha abantu abanikwa amayeza kuthiwa amayeza awekho. Okwesibini, ndiworried kakhulu kule nto yokuba udepartment makasincedise into yoba kuqashwe abantu. Kutheni ntoni? Oodata ntoni? Oodata abakheptshalisha ii-files.
Akekho eNxorha, ibingoka TBK. Umkile uTBK eNxorha. Ndizibuza umbuzo omnye ngubani na ngoku na okhona na okhupha ifayile okanye ngumuntu omnye nomnye nje oklinayo okhupha ifayile ngoku ngalomzuzu. Ibe yilena yabantu abamisisha idate. Abantu bajikisha kwiikliniki zethu bethunana. Omnye ngumuntu omdala akayibonanga elaa khadi into yobana libhalwe AP date. Ahlale mhla esiza uyajikiswa akancedwa nokuncedwa. And mhlawumbe ukhwele ngemali eninzi. And kuyareyishwa kweza lali eziphaya eNxorha. Kusemakhaya apha abantu bayareyishwa. Abantu bayabulawa. Abakhathali tu. Ibe yi-attitude eyaphaya ekliniki ke ngoku yona xa ungena uzobhalisa. Aba nompilo ke ngoku impilo ke yintoni andiyazi. Ngumuntu omdala ungumntana. Indlela abathetha ngayo ayikho right tu kwaphela. Ungena pha ngaphakathi. Oonesi babini kwindawo eyi-1 bazoncedisana ngomuntu omnye. Kuyahlekwa. Xa ephuma uyaphuma uyolanda omnye azomamela le nto ethethwa ngulo. Khawuphinde le nto ubuyithetha. Umuntu uphuma enjani pha ngaphakathi. Awuphinde umbone. Kube khona indawo yokukhansilisha abantu ayikho kulaa kliniki bendikuyo. Bendicela Tata uSomayele makhe kubheka kulaa kliniki yaseNxorha. Ezinye iikliniki ezinje babahlale sebegcina into basibancedisa. Angeke siluze impilo zabantu thina usisintsiki into yobana nifuna sibuyele kulaa nto yokuba ikliniki. Asisafuni udoktor. Sifuna abantu batye i-treatment bafane nathi sithi sina 28 years siphila nentsholongwane. Sina 29 years ndiphila nentsholongwane. Asifuni ubona abantu bababhubha. Ngoku kuthiwa i-treatment ikhona but abantu bayabhubha. Abantu abayizikliniki, abantu bayadiclose. Nezi NGOs ezikhona bethunana. Sicela ke zibizwe, sizohlala phansi nazo apha. Ke zifundiswe. Because uTBK bethunana le moto yabo okanye ezi abaziharishayo okanye baziharishela for thina andazi. Le nto ethethwa ngulaa bhuti into eyenzekala kulaa Nxorha. Abantu bayadefaulta i-treatment bayiyeka. Xa ufika umuntu athi ibikhona imoto yaka-TBK apha izile izise iipilisi zam bafikile bathi ndiyafuna ekliniki. Bazishiya iipilisi apha. Akho mntu ongakwazi into ipilisi le ye-ARVs. Abantu baphucukile ngoku. Ake sizifundiseni kwathina bethunana. Abaphezulu abaphethe banisithi siphethe. Kuthiwa siqeqesheni abanesi abapha ekliniki nezi moto ezi zaka-TBK. Ndikhala ngo-TBK mna because yiyo imoto endiyazi into yoba iququzela ulanda abantu. Nalaa bhuti laa moto yimoto ka-TBK. Ndiyabulela.
Amandla. Amandla. Qina mntu ophila negciwane qina. Mandibulise i-department xa iphakathi kwethu. Siyayibulela elithuba. Ndibulise ne-leadership naku-national ne-province. Mna into endizayicela nje zimbalwa ndizazicela kwi-department mna bengumphako ehamba nazo. Ndiyayicela laa i-counselling phaa kwi-counselling straight. Into endiyicelayo phana makhe siyeke le nto kuleqa i-target ngoba i-department ileqa i-target. Sicela ke makhe kube khona abantu baphila negciwane phaa kwi-counselling room ngoba ngenye yezinto eyenza abantu bethu bangakwazi ukuthatha i-treatment. Okwesibini nje into endizawuphinde ndiyicele beseyifakiwe ngabane wethu yilaa nto ye-data capture. Nakhona ndiyacela i-Department of Health mayisincedise. Mayikize kule sector izothatha
aba bantu sithi banazo imetricana ike yoba trainer ibafake pha iyowenza ngoba ifolder zethu zihleli pha zipakishwe pha kuthiwa awusayi ekliniki ube ubuye izolo awukheptarishwanga mawufika mawubuya kulaa date kuthiwa wawugqibele kunyaka ophelile kanti akhange bakheptarishe. Siyarhalela ukuthi makhe sizenzele lo msebenzi zimpilo zethu. Hey, hayi le iyandidanisa kakhulu ke ndicinga uba ke istafu kwezi facility noko xa ziyasayinwa i-code of conduct ngoku andiyazi okanye funeka ndike niphinde Tata Somayela ndike nitshekishe okanye abanye bangena nje azange akho kwanto abayenzayo. Indlela le noko othetha ngayo nomntu sifunda kwasekhaya mos sifunda back emakhaya before ndiye emsebenzini wam ndifunde phaa ekhaya andinokwazi nje ukuthetha ndithe mandimamela izitori apha abanye ngabantu abadala umntu omdala awunomjikisa umntu omdala noba bezenini na noba angafikanga ngo-3 funeka uzame ukumnceda aphume encedakele. Xa uzawujikisa umntu omdala ungabi nayo nepeni le eyokumbhalela ngoba umkhathalelanga uthini ngomzali wakho phaa endlini uthini ngumama lo wakho phaa endlini ngoba uyamazi yena qala umntu omdala uba phaa endlini ke ngoku xa sowudibana nalona awusamazi. Ezinye izinto zindivise ubuhlungu okukhulu andifuni ukuthetha kakhulu. Enkosi.
Amandla. Thank you very much kwi-PL HIV sector ngale report. I-detailed kangaka iyasinceda siyi-community. Number 1 ndizawuthi mna kwi-Department of Health thina as PL HIV sector asiqali le level yokugqibela le provincial accountability meeting. Sine sub-district accountability meeting, sine district accountability meeting, sine local accountability meeting whereby we hold accountable or sister in charge be facilities. So xa ize kule level sebe ikwi-level yokugqibela. Number 2, I would like a department if maybe at a local level can copy a strategy esenziwa i-Department of Education by calling abazali, by calling i-community to give feedback yokokubana siqhuba njani in terms of budget of the facility, in terms of medication, in terms of zonke izinto ezenziwayo. Sidla ngobizwa phaa ezikolweni sibizelwe into kokubana ngoku kuphela unyaka nansi report yeso sikolo. So if i-Department of Health ingenza kanjalo ingabe iyasinceda kakhulu. Number 2, the issue of i-link between the hospitals and the clinics. Ukudecentralizwa kwe-services. Umbono esiwubonayo phaa Mr. Somayela whereby abantu bethu have to travel long distances nge-patients transport. Abengabikho umntu for 3 days elele esibhedlele elindele uyofumana i-treatment i-ultrasound at Mthatha General or eMadzikane Hospital. Ufike phaya niphinde nijikiswe kuthiwa the doctor is not available. So ndiyacela into kokubana if ninowubona ebusuku indlela abantu bethu abalala ngayo ezibhedlele nendlela abantu bethu abalambe ngayo xa behamba ngala patients transport. Okwesithathu kokokuba ndiyacela an agent intervention kwezi PE facilities. Sifumane reports whilst we are here ukuthi abantu abafumani treatment Nelson Mandela Metro. Njengoba besetshilo uComrade GS, ndiyacela into kokubana umba wase Nelson Mandela Metro ujongwe as umba okhawulezileyo because abantu bazawudefaulta. Lastly, the issue of services of abortion. Besikhe samonitorisha i-services ze-abortion kwi-facilities zethu azikho friendly, Tata Somayela, at all, especially the Mthatha Gateway Clinic. So ithi ke ngoku le nto i-department ngase ikijonge into kokubana sinelungelo lokwenza i-abortion. So xa sinelungelo lokwenza i-abortion masifike kwii-facilities, ii-facilities zi-friendly kuthi zisivumela senze i-abortion singathukwa sithuke. We understand into okokubana nurses zine-rights zazo zokuba zingayenzi i-service. Xa zingafuni uyenza i-service mazingayenzi, but ezo zivumayo ukuyenza i-service maziyenze. Lastly, the issue of KPs. Services of KPs are very important. Xa sithetha nge-lubricants, xa sithetha nge-dental dams, xa sithetha nge-finger condoms, ingathi sithetha kwelinye ilizwe. Xa sithetha nge-hormones, the stories abathetha ngazo abantu kwi-community zethu in terms of i-KPs kunye ne-LGBTIs, zizitori ezo ii-clinics zethu ezingekho friendly kuzo. So if maybe i-department, umzekelo kuthiwa ii-lubricants zikhona but ii-nurses azikwazi uba zizazisebenzisa entweni ezi lubricants, zihleli esitoreni zikhona ii-lubricants. So ithi ke ngoku le nto siyayicela ungenelelo. Otherwise, Mr. Somayela, thina sizulinda le platform nanini. Le platform i-formality nje yokuba zi-address izinto, but xa zinga-addresseki izinto at a local level, kuzawunyanzeleka into okokubana sithathe amanye amanyathelo. Enkosi.
Thank you, thank you, thank you. I am told that IPEPFA ba offline, and also in National Department of Health is not going to respond. Bakhona nje bazomamela ngoku sizawuze ephondweni. I do not know Geta Somayela nani mama, but whether because thina sine arrangement for i-response kwi-district and i-province, so it's up to kwi-department arrangement yabo whether kuzawuresponda umuntu oyi-one okanye you will follow our arrangement. But I think there masinike uTata Somayela uzasixela yena uba ngubani ozawurespond. Masimnike i-mic. Right. Over to you, Mr. Somayela. Uzawuza ngapha efront, funeka simbone pheka ukhamera uTata Somayela.
Amandla. Amandla. Ndingumhlali nam bethu na. Mandiqale kule ndawo itshoyo. Mhlawumbi mandiqale ngelithi comrade Yewa mase appreciate le report uqala that you esherishwe apha. Njengoba sitsho uNoloyiso that this is a very comprehensive and detailed report. Ndifuna uqala ke si-acknowledge into ethi as ubuke watsho ngaphambili into yokuba le report has been presented to MEC on Tuesday. Unfortunately ke ndingene seyibuphela kuyo lo meeting, but I got a report in details as a someone responsible for the program. I have shared the report with all the relevant managers that are responsible for all the various issues as mentioned in report beni presentile apha ngoku. And it's a very comprehensive report esingenawukwazi ukwenza justice kuyo if ndingavele ndithi ndiyaresponda kule report. It will not be in a good I will not be representing the report and responding to the report ngendlela efanelekileyo. But it's just for me on behalf of each department to indicate that a report is acknowledged and is received and will then be taken through a process of being shared further with an intention all the issues that are mentioned in the report are attended to. And ziyakuya respondwa kuzo. Ndifuna acknowledge again into yokuba maybe for noting leadership into ethi andihambi ndedwa. I've got colleagues from the head office, Umama Geisman, who is responsible for and representing what we call clinical support services. Apho kudilishwana quite with number of areas as include phakathi kwazo ambulance services, as you were mentioning, the transportation of patient and TPVs, patient PTVs, patient transport vehicles, the experiences of patients that are being referred. Ulapa, I also have Mamuti PS, who is representing what is by district health services. District health services is a component department in ejongene kanye ne-platform. Kasithetha nge-platform, ojongene kanye ne-district health services, providing technical support from a provincial level of strengthening its services as provided in terms of the platform. Yabona ke le report, I do want to acknowledge it's very comprehensive, while the content yayo and the focus yayo is around HIV management. Your management ke HIV ayenzeki in the vacuum, yenzeka kwi-facilities. And the interventions and recommendations ezivele apha have to be implemented at a facility level. Ifuna ke ngoko therefore that we engage with all the people about responsible to ensure that all the recommendations, we find a way of making sure that they are implemented. I thought I needed to respond on one thing for you to note. There's quite a lot of alarming and heart-hurting statement as presented apha ngaba bantu bebethetha apha naba bantu bebenezi-clips that were presented up. One of the things enfuneka siyazi as a community is that besides la box your complainer, a opportunity yokuba thina singabahlali, we need to raise how we feel about the service esigqiba uyifumana kwi-facility. It's a commitment that the department has created. Further than that, there is a call center. I'm not sure how many of you are in the call center, which is 24 hours for you to call anytime you experience and a service ongayithandiyo. You pick up the call and call is a toll-free number. They can even call you back if awukwazi ukuthetha. Inamba yayo nansi ngu-088 sorry ngu-08 000 ngu-08000 o-0 abathathu ne ibe ngu-323 64. This is a provincial call center esebenza 24 hours a day. If awufuna uthetha nalo sister nalo manager okanye nalo lapha kwi-facility, call that number. It's an independent, it's not facility, it's where the highest level of coordination of complaints and management of your complaints handles your call. And your matter will be listened to and be responded to and followed up. Eastern Cape, the call center, comrade yaw, considered it's one of the best call centers up in South Africa, Eastern Cape call center. If awukho happy nangayo ke, I'm sure you do have access to leadership, call ka MEC. Ndifuna ukuthumela ke to the highest authority at department. But having said that, comrade yawa ndine-agreement nezi leaders la. Bangaphika utshoyo ophikayo. Into okokuba, I'm available to them 24 hours a day. Ngaphandle kaNdlini. I'm available for them and they know it very well. Anything and anything affect I'm a patient at treatment, I deal with it right then. I thought we have that level of commitment and understanding between ourselves. That if you want, if there is any patient they experience facility ingena treatment, you are free to call my number. And ke umntu ogudu kule nto ke, Mr. Lucid, Comrade Lucid. Ezinye izinto ndiqonda uba hey ezi azindifuni ncam kodwa ke ndincedise. Ndifuna ukuthi the first line of contact besides the call center nento ka-MEC, but when it has to do with into yokungakwazi ukumanejwa kwakho kuba ukwi-treatment ye-HIV, I'm your first point of call. I'm making that commitment in the presence of leadership yalapha. And all the managers as khoyo in the department, I'm sure the district managers are always ready to listen. And that's one of the things, comrades, and for now we encourage, but you must have the contact number at this manager where area ohlala kuyo. You must know of phone number womuntu esimbiza ngokuba ungu-house manager. Okuthiwa ngo-house manager, a-house manager responsible for the program kwi-district ohlala kuyo. If ufumana into yokokuba awuncedakali ncam, I'm available to assist in all of those things. What in all that I'm saying, leadership, the community at large as a Eastern Cape representing is that as a Department of Health, we are willing and ever ready to work with everyone who wants to assist in improving its services in the Eastern Cape. We are committed as a department to that. But all the things that have been reflected there, we are not going to deny them, but we will need to find a way of how we deal with them. And we are going to be following that. And all these clips, I want to request, if possible, we can get as clips, as video clips that were presented here. So that in our engagements with our management at local level, we share these clips so that as izinto zithethwa abantu bazive directly, bangazive indirectly ngathi at a provincial level. And the last point, I hear that Madam, you do have this consultation session. But I always, from the beginning, Ritshidze, and I tell when I went to introduce them to a OR Tambo, kusekho ke uComrade Vovo ngoko wayeyiqalile project. I made it clear, colleagues, that the first point of contact in solving this program is your facility manager. If your facility manager is not assisting you to solve that, what district manager will call to deal with this issue so that we know in advance and upfront there are these issues that are being lifted up by comrades who are doing the assessment. Singayoiva from coming from national. You understand a lot? And we will then be expected to respond. I am requesting that we communicate these issues straight when as they happen. But they are attended to straight away. I am just saying that, colleagues, I'm appreciating this response, this report, and we're hoping and committing that it will be presented to all the relevant structures as a management. There was even a view, Comrade Yawa, that following the presentation of this report to the MEC, the report is presented to the extended management meeting at provincial level, where even the district management is part of that structure. So it's something that we are working with through the office head of department, so that we will, if that succeeds, we will try to invite you again to present this report. Enkosi kakhulu.
Thank you, thank you. Amandla, 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 Amandla. All power, all power, all power. Before we close and before I thank everybody here, including Mr. Somayel, Siswam, can we find treatment? Sati apa sihamba ungayifumenanga treatment. Can you come forward and tell us ungoncedo luka Mr. Somayel through our intervention whether uyifumene treatment okanye akuyifumenanga? Iza ngaphambili mntazi. Uzosixelela mntazi.
Molweni mandithathe lithuba ndibulise. Bendithe i-treatment andiyifumenanga ndisuke ekliniki, i-treatment yam ndiyifumene.
Siyabonga Mr. Somayela, siyabonga comrades who assisted the comrade to go to the clinic, but we do not have to go this mile in order for people to get a treatment. Eh, As I'm closing this, Mr. Somayela, Comrade Ndivu and Comrade Loti would like to get some of these clips being sent to him so that as they are going to have number of meetings, he is able to play these clips. Also, with regards to the Nelson Mandela Metro NU1 clinic, I am told ukuthi Mrs. DeForce is no longer a district chief director. Mama Ulupondwana, district chief director of Nelson Mandela Metro, which I think after this meeting I need to call her so that I can make a follow up about the issue yeza clinics. Also, as we are closing, Ukomrade Sibongile spoke about Ingoha clinic. Yoguti, on Fridays, Ingoha clinic does not open and it doesn't provide services to the people. She also reported to Ingoha clinic. Most of the times, people leave the clinic empty-handed without having medicines. But to her surprise, she often sees staff at Ingoha clinic disposing in medicines that have expired. I think Mr. Somayela and all of us, we need to monitor that. If a Ngoha clinic or any clinic in South Africa, more especially here in Eastern Cape, does not provide services, I clinic has valango 2, body, BCD ivalongo 1, masingathuleni bahlali. Ngono sibe zimbimbi about izinto ezirongo ezenzeka clinics but masingathuleni. The toll-free number Mr. Somayela asinika yona ithi 0800 32364. I ask you, comrades, let's test and treat this toll-free number ukuthi iyasebenza na to resolve ingxaki zethu, so that if I sebenzi, we can be able to come back and inform Mr. Somayela whether that toll-free center is working or not. Also, around the termination of service of pregnancy and key populations services, Mr. Somayela and everybody in the department, those nurses who are denying or who are discriminating against people because of their sexual orientation, because they want ETOP services, we cannot allow them to do that because of their political beliefs, because of their cultural beliefs and religious beliefs. These people are hired by the department to provide services. Whether Umdu believes on this service or not, all what they are paid for is to do these services. Please assist us in ensuring that people are not denied services because of the beliefs of certain individuals. We are not asking a favor here. This is our constitutional right, and we need to see this right being realized. As we are closing, let me take this opportunity, comrades, to thank the community members, those who are in-house and those who have connected in different viewing points. Let me thank the Department of Health. Let me thank PEPFAR, UNAIDS, and all the agencies. Let me thank the media and the journalists who are watching online. Let me thank the comrades who made sure that this gathering becomes this. But as we are saying as Ritshidze is all about us saving our own lives. Because we have since realized that if we as people living with HIV, key population and public healthcare users, we do not stand up and speak out against the injustice, against the violation of our rights, nobody will do that. And we are not apologetic about that. When we go to clinics, comrades, and we are being insulted in clinics, let's use this toll-free number. Comrades, let us name and shame the nurses who are ill-treating our community members. If it means that they must be dismissed, let it be. But we need to see action being taken, because what we're not going to tolerate is to keep on reporting, nothing is being done. If the department is failing to act, we will assist them on how to act against those nurses who are ill-treating our people. But I must make it clear, Guti, not all nurses are the same. Not all of them are the same. On that note, I will ask umfundisi wami uNyawondle uRev Boyan asiyalezele kuThixo kwakhona ukuthi siqhubile le meeting ngentando kaThixo hayi ngentando yethu. As we are walking out, lunch will be served outside. Sonke we are welcome, comrades. Over to you mfundisi wami. Yebo. Asimnikeni mic uqabane. Ibambe. Sakunika mic.
Sorry to interrupt while you are talking. Me as a community member, I wouldn't like Umfundi to close without us saying something. We also have to be thankful of what happened today. First of all, I would like to thank Ritshidze for the marvelous work which they have done and the work which they are doing. But on the other side, I'm also worried. What makes me to worry is that I believe all the testimonies that have been done or the stories that have been told here, it's the people that are going to the clinics that are monitored by Ritshidze, am I right? Where there are other clinics that are not monitored, Ritshidze, but are having so much crisis, more than the crisis which Ritshidze has managed to solve. For an example, as I'm sitting there, I'm thinking of a clinic in Fort Grey, all right, which they are having so much of what has been said here, even more. My name, firstly, I'm Sonabisi Trevor Jonas. Ne? I'm the chairperson of men's sector at BCM. But sometimes we are wearing shirts that are writing HIV and AIDS. So one of the ladies that goes to the clinic, a PLHIV person, all right, they came to me thinking that I'm also representing PLHIV. But because they're from the community or in this London, I managed to listen, all right? I find out these people are having a problem of defaulting. I went to the clinic myself in fourth grade to go and intervene, to check out the story which they were given. Comrade, yes, you wouldn't be surprised. I went there, I sat and I checked. What they told me, I witnessed it. Luckily enough, I've got comrades for your organization that can agree with me. Comrade Dira and that beautiful lady next to you. Because they managed to come and intervene or interview the occupiers there, sex workers, drug users, and so on. They got the story from them. But my worry now is that clinic is not under Ritshidze. All right? Now, Department of Health, as they are saying, it's not something new to them. These things that we've been given here to solve the problem, they've always been there. But the problem is expanding. My request now is to TAC, can you please intervene at the clinic in Fort Grey? What makes me to say that you, the people who had fought for those rights of those people, all right? But now they're not getting those services. Please intervene. There's no place than Fort Grey that is defaulting, Comrade GS. People are dying where you guys had fought for them not to die. Please, KC, intervene. Thank you so much.
Thank you. I think, comrades, it was an omission on my side. Ngexesha besenhlanganiso kunye no-MEC of Health, sivumelene ukuthi after this meeting, we're gonna go back to the department and suggest a date for a follow-up meeting where we'll discuss a report and also discuss about the problems zezinye iclinic wenandira. Uslow, comrade Utogo and other comrades, they've got a list of other clinics as outside the Ritshidze, ne problems azo. Simcelile u-MEC ukuthi am invite u-HOD so that u-HOD yena u-invite all district chief directors sebesonke kula nhlanganiso kwenzela bangamana xa sisithi eMatatiela abe khona u-district manager waseMatatiela, xa sithi eNelson Mandela Metro abe khona u-district manager of those districts. So we are going to cover even if facilities that are outside. But Abumayel, uthi comrade kuya defaultwa e-Fort Grey, and we cannot go and sleep as if nothing was said. People living with HIV are defaulting, and the majority of them, they don't default because they want to. They default because of number of challenges that were raised here. Funyawontle, over to you mfundisi wami. Because ndawuthetha kude kusa.
Masimengenya. Masivaleni amehlo.
Thank you very much, Mfundisi. The meeting is adjourned. Amen. Ngegama kaYesu. Meeting iphelile maqabane. Thank you.
Thank you, thank you.